So, good morning everybody. I'm myself Dr. Raman and welcome you all to this place. I hope this will be a very informative and knowledgeable session. I am myself looking forward to learn a lot of things from sir. So let's welcome Sumant Krishnan sir from Hyderabad. Sumant Krishnan sir is MDS in oral and maxillofacial surgery. He has done his BDS from Government Dental College, Vijayawada, and MDS from Kamini Institute, again from Hyderabad. He is a university gold medalist, practicing basal implants for last 6 years and mentoring doctors, students for GS implant for past 1 year. We also have privilege to have Dr. Shishu Kumar sir with us. He is an MDS periodontist, owner of GS implants, and he is practicing basal implants for last 6 years. So I know most of you, right? So we have periodontists, endodontists, and a lot of people, I guess. Vinny sir bhi to endodontist hi hai sir. Oral surgery, yes. So we have a lot of PG guys, BDS guys also, and most of us have placed implants. So we all are here. I am personally taking this lecture to know basal implants. So let's welcome sir.
Thank you.
Sir, वो कैमरे में एक बार. ये. Sir, small bouquet for you.
Thank you. So good morning all. So obviously you know my name by now, so let's not dwell into that thing. I welcome all, and first of all, Happy New Year to all of you.
Thank you, sir.
So we just started a new year, and I hope today's session will be, if not in detail, but at least will be little more, definitely will be more informative for you guys, right? So the first slide itself, answers a lot of questions. Why are we here actually, right? So you're all practicing, right? You're all already practicing in your general practice already, right? Probably a lot of you guys have been doing implants also, right? I was just listening to Dr. Raman also, right, downstairs, where he just told me that he has already finished almost 11,000 implants, right? Conventionals, right? That's good to know. So, what exactly is that you wanted to learn today? That is because from there we can go forward actually, right? Because otherwise, what will happen? Let's make it a more interactive kind of a session rather than I just keep on just going on telling. I might find somebody sleeping also in between. We don't know, right? So instead of that, if you can make it more interactive, right? So I think it will be more better. What do you say? Yes. Right? So what exactly are you expecting? Anybody? Means you must have come all the way from your places, right here. I don't know how far it is, but yeah, definitely you took out some time on Sunday morning, right? And then you came here, right, to learn something. So what exactly is that you are looking out? Sir, can you please tell me?
So we use surgical and easy for the patient and for us also.
Okay.
And long lasting.
Long lasting. Okay. You sir?
Just some new things about the implants.
Okay. Do you practice conventions?
No.
Let's not say conventionals with two-piece implants, basically two-stage implants. Are you practicing right now?
No.
No, not right now. So how many are practicing two-stage implants on a regular basis? All of you, almost, right? Other than one or two guys. So everybody is practicing, right? Even 6 years back, even today also I practice, means I do conventional implants. It's not that every case I just go on doing basal implants. And there is nothing against doing any conventional or basal, right? It's just about, depending upon the case scenario, right? That presents to ourselves. We decide whether we have to do a conventional or a basal, right? So it's always better to have the knowledge of both, right? So let's not be too much fur towards conventional, or let's not be too much, biased towards, the basal, right? Let's see them in a neutral point of view. Now, so the point I came all the way here, see I have done almost like 38,000 implants now, right? 2-piece implants for the past 12 years. Okay? So, shifting from a 2-piece implant or a traditionally means whatever we have learned, right, during our PG days or before the PG days, right? Shifting from that concept to this concept, it was actually like a paradigm shift for me. It was not so easy, right? Dr. Raman will agree with me with this, right? It's not at all easy actually, right? Because the concepts are actually totally different. The concepts are actually totally different. In the coming slides we will come to know that. But as I already said, depending upon the case, you need to have that, freedom of mind where you can actually judge the case accordingly and then go ahead with the particular implant, whatever, we want to do in that, keeping the success rate and as just I was mentioning about, the patient's comfort, right? So ultimately, that is more important than anything else. It doesn't matter, which implant you are doing, right? So now let's get on with the topic. So just to brief about, means you are already doing these kind of implants already, right? We all done this. So it's nothing but a conventional or a 2-stage implants, right? Where basically you place an implant, right? Wait for a 6-week time period, depending upon the type of the bone. You can probably wait for 2 months or sometimes 3 months or 6 months, depends, right? And then at the later stages, you place an abutment and then give a crown over it. Basically a conventional, means a traditional kind of an implant, 2-stage implants. Next is the basal or a bicortical implant, right? Now the term itself indicates. See, I just want you to understand one thing here. You can always, nowadays, why it is called as a basal or a bicortical, right? So basal means basal bone, right? Bicortical means what? Anything that engages 2 cortices, right? It can be either buccolingual, right? Or it can be crestal and the basal, right? So based upon this concept, it has come actually. And if you see the history of the bicortical, how many believe that it is a very new concept? How many of you think that it's very new? Right? Right? It's very new, right? That is what even I thought. Right? But basal implants, right? Probably we did not do it in India. Right? It has been there for the past 25 to 30 years. It's not something new, right? We actually don't know about it because none of our seniors, the people who came before us, nobody focused on it or nobody taught us. Somebody was oral surgeon here, right? Yeah. 2 of you? Whenever I see oral surgeon, I feel so happy because same faculty, no, right? So, anyways. You remember lag screws, right? When we do in a long bone fracture, right? So generally there is a proximal and distal segment, right? Whenever there is a fractured bone, there is a proximal and a distal segment, right? So what you generally do in a lag screw? Basically you just drill a hole, right? For a lower diameter and then a higher diameter screw, you just go on rotating it. Then the distal segment is actually pulled. Right? It itself pulls. Right? Based on the similar concept, the basal implants have actually been developed. Right? There is nothing like a pulling here. There is only fixation here. That is the only basic difference. Right? And they're almost all are, if you see the thread structure, rather than if you see, you all have seen the conventional implants, right? Right? Not much of an active threads, right? But if you see here, right, very robust and a very active threads you have in cases of basal implants, right? And if you see the surface area, means between each thread is also more. Actually, the engagement of the surface area is more in cases of the basal implants. Okay. So now, one of the old concepts basically, right? It has, that is what I just explained, active threads, basically self-threading, right? And now let's go into this, if you remember, this entire table, right? It will clear a lot of confusions. Whether should I do the basal or should I do, the conventional implants or whatever it is, right? Now let's discuss about each point, right? The first and foremost is the principle itself, right? Based on which concept basically both of them work. Now if you see the conventional implants, they basically work on the concept of osseointegration, right? So basically you put it in the ulnar bone or the crestal bone basically, right? And then it will engage, means it will integrate with the parent bone there, right? In a due course of time, 6 weeks or 8 weeks or whatever it is, right? So that is about the integration, right? But if you see the basal implants, right, they are actually based on the concept of osteofixation. Integration happens very late. It will happen, but slowly, means probably 1 year or 2 years or something like that. But not in 6 weeks or an 8 period time period, right? It is nothing like but like a screw fixing in the wall. Or we do fractures, right? Mini screws. It's the same concept. But the thing is that they have a high surface area and there are active threads, right? The fixation will be very rigid fixation. Okay? So they are basically based on the concept of fixation, not on integration. Integration happens in a very late stages. Right? Now, success rate. See, these are all points, whatever I mentioned, these are all my own theories. They are all based on the articles. Okay. Now, if you see the conventional implant, right, the success ratio is approximately 95%. Right? But if you see in the cases of basal implants, right, approximately 98 to 99% is the success ratio. Right? There was a published article regarding this, right, in the Brazilian Journal of Oral and Maxillofacial Surgery. Right? So in that, what they have done, on a 5-year follow-up, right, approximately they have placed 1100 implants. 1100 on a different age group, starting from 24 years to 78 years of age group. Different age group. Right? Whose like diabetics we had. Right? So on a 5-year follow-up period, right, what they found out is 99% of success rate. Over a 5-year follow-up. We are not talking about 1 year or 2 year. Right? So if it is a 5-year follow-up generally, so we can trust on that. Right? So they got a success ratio of 99%. Right? It is available. Actually, if you can go online, you get this article also. Right? And then loading. The difference in loading is what? In cases of conventional implants, delayed loading. Right? Nowadays they say that if it is a mandible, specifically if it is a mandible, even for conventional implants you can do an immediate loading. Right? If you get a very good torque. But how many people will take that risk? Is again a questionable thing. Right or wrong? Because there is always in the mind, back of the mind saying that let me wait for 2 to 3 weeks at least minimum. Right or wrong? How many of you can confidently load it immediately? Right? Very few cases. Right? But it's not mandated that every case you will get a D1 or D2 type of bone. You might get a D3, D4 most commonly actually. Not every individual will come, right? That is wrong, right? So, in cases of conventional implants, the loading cannot be immediate. It has to be delayed. And let us say if you are dealing with a radicular cyst, let us say in the anterior mandible or in the anterior maxilla or in the posterior region, right? There is a small, very small, 5 into 5 mm, let us say example, right? Still you have to wait, right? At least for 2 months or 3 months, right? So there is always, a delay in loading. But in cases of basal implants, it is 72 hours. It's not an option, it's mandatory. Understand this. It's not an option, it's not a choice. It's mandatory that you have to load it within 72 hours. Why? Because there is a peak osteoblastic activity within the cortical bone in these 72 hours. Right? Otherwise the chances of failure are more. So within 72 hours, even though let us say you are doing an extraction case, right? Let us say you are doing multiple extractions on the same day you put an implant, right? Because the tissue has to heal, the soft tissue healing has to be completed, right? So it will take 1 month time. So instead of giving a permanent structure, right, processes, at least you have to load it with a temporary thing. Within 72 hours. And that too if you are not welding also, means if you are not welding the implants together, that will come in the later stages, I will explain it what it is, right? You have to mandatorily, there is no option. You have to load it within 72 hours. Now just imagine, right? If a patient is with an aggressive periodontitis, right? Having a lot of, means tooth extractions or whatever it is, if you can rehabilitate him or if you can make him functional within just 3 days, if he is able to eat something rather than nothing within just 3 days of time, don't you think, he will praise you for his lifetime? Right or wrong? If you are really thinking in the patient point of view, right? Permanent again, you can wait for 1 month, right? Once the soft tissue healing, all the shrinkage, everything happens, remove the, the temporary structure, and then you can always give a permanent structure. Clear? Right? So next, sizes and designs. Obviously the conventional has a limited range. Basically, duration is 72 hours, or immediate loading also you can do, 3 to 8 months depending upon the condition. Loading, right? Depending upon the situation, you need to wait 3 months or 8 months or sometimes 1 year also. Sometimes, I'm not saying every time. Right? When I was doing my post-graduation, we waited, almost like 6 months. Now what we did, the patient was totally, that time I don't know why my professors even did not think about basals. Right? So that time there was totally resolved maxilla and mandible, so we actually took a ear graft, right? And then we had to totally, augment the ridges, wait for 6 months and then we gave an implants. Right? So, but how many people are, nowadays ready to go for a second surgical site? Right or wrong? Right? How many people? See, all these fancy things, I'm sorry to use this word, right? All these fancy things, right? That I will do iliac and all these things. Private practices mein nahi chalta hai. It is only actually restricted only till the institutes, right? How many, you tell me the private practices, you can actually confidently say that, come on, let me open up your hip bone, let me take the iliac graft and let me put it. No way. Right or wrong? See, when you are reading all these things, very fanciful, very nice. But when actually it comes into practicality, difficult. So by this what will happen? We lose a lot of cases. Right or wrong? Because you don't know the concept of basal. When you don't know the concept of the basal implant, it means not about basal, at least when you don't know about an alternate to the conventional implants, so you tend to lose the cases. Right or wrong? So, and nowadays patients doesn't have that much of patience also to wait for 3 to 8 months. कोई UK से आता है, कोई US से आता है, right? And then immediately they will say that in 3 weeks time I am leaving. Tomorrow I am actually operating on a case, full mouth. That guy has to leave within 2 weeks. So they are like that only. Because in a very limited period they will get leave or some visa or something like that sometimes. They come, Doctor Sahab, मेरे को 2 means 2 हफ्ता time है, please कुछ कर सकते हैं क्या? See, best option, Basal. Right? If it is an extraction case, warn the patient. After 6 months at least can you come? At least for 2 days or 1 week and go back? Right? So give it temporarily. Anyways the tissue shrinkage is there. At least his function is not hampered. Right? After 6 months he will again fly down. Right? Give a permanent in 1 week's time, let him go back. Over. Right or wrong? Okay? So, and then basic difference, very major difference is what? Bone augmentation, sinus lift, grafts, all these things, in conventional you have to do. Right? All this sinus lift and all these things, right? They are technique sensitive. Right? Not everybody is trained to do that, right? You have to again go and get trained for that. Or you have to call a consultant for that. Right? And if the consultant is from the same town, what does the patient think? I have a better doctor actually in my town than this fellow. This will happen. If you are actually practicing in a small town, right? In cities, well and good, means far off. But actually if we practice in a small town, definitely this is bound to happen. Right? And not every patient, is not willing for sinus lift, grafting and all this stuff. And mind you, right, as a surgeon, because I have seen a lot of cases, I have done a lot of cases, there is nothing equivalent to autograft. Right? Agreed on this point? Any allograft is inferior to autograft. Right? So when you put an allograft, you cannot actually give 100% success to the case. Right? But if you want to have an autograft, first of all, again, you should be trained to do that again. It can be even from the small place called ramus of the mandible also. If you want to remove an autograft, or from the symphyseal region, or from the iliac. Right? So you should be trained for that. And you require an equipment for that. Right? So all these things can actually be avoided in cases of basal implants because we are actually not dependent upon the crystal bone. Clear? Right? So next is what? Eligibility of the patients, conventional implants, not suitable in diabetics. Right? Obviously in aggressive periodontitis cases or uncontrolled periodontal disease, smokers, right? Chronic smokers we are talking about, right? So generally are not the ideal candidates for. Now why diabetes is not suitable? Can anybody tell? For implants, we always say, अगर आपको sugar है, तो नहीं कर सकते. क्यों नहीं कर सकते? And why actually basal can be done in diabetics? Anybody?
So periimplantitis and with surgical procedures.
Yeah, surgical procedures, what is it is right. But I can put an antibiotic coverage and then I can do, right?
Yes.
Right. But why we can't do in diabetics? Perfect. And that too specifically marginal bone loss. Right? A lot of periodontists sitting here, they'll agree with me this. Right? Don't you think there is a marginal bone loss, sir?
Yeah.
Right? So whenever there is a marginal bone loss, what will happen? The chances of peri-implantitis is more. Why? Because of the rough surface of the implant. Right? But in cases of basal implants, we are actually not dependent upon the crystal bone. Even there is a marginal bone loss, no problem. We are actually engaging in the basal bone or the cortical bone. Clear? Right? So next is what the bone used. Conventional, basically the crystal bone or the alveolar bone that is of less quality, means less mineralized basically. Right? More of a cancellous part. rather than of a cortical, right? But here, basal bone of high density and mineralization. Right? Now, very important point, peri-implantitis. Right? Can you actually confidently, see I told you, right, I have done almost like 38,000 implants. Basals, I think I have done around 22, I think so. Right? See, most of the two pieces implants, right? Most of the two pieces implants, right? Okay. So most of the two piece implants, right? Some or other way, you start developing peri-implantitis if you actually don't maintain them properly. Right or wrong? Right or wrong? Now what are the reasons? First thing is this surface of the implant. Right? Basal implants are not smooth surface implants, they are rough surface implants. Right? Whenever there is a rough surface implant, what will happen? The conventional two-piece implants are rough surface implants, right? Whenever there is a rough surface, what will happen? The accumulation of the smear layer happens. Remember all of this, right? Smear layer. Once the smear layer is formed, what will happen? The colonization, debris, everything will happen faster. I don't know, right? And then inflammatory. Right? So it leads to peri-implantitis. One reason. Same reason now if you see in cases of basal implants, they are highly polished surface implants basically. Extremely polished surface implants. So the chances of smear layer formation is nil. And there is no accumulation of debris or colonization of the bacteria. First reason. The second reason, the penetration diameter of the soft tissue. Right? Lot of periodontists will agree here. If you raise the flap, the chances of peri-implantitis is more or less? Or bone loss is less or more? If you raise the flap? More? Right? Even the wider the diameter of the punch, what will happen? The chances of again bone loss, the marginal bone loss is more. So the chances of peri-implantitis is more again. Right or wrong? So that is second reason. Now if you take in cases of basal, the penetration diameter is very minimal. Most of the cases I use only one drill, that is 2 mm drill, that's it. Not more than that. Right? Most of the cases. If I am doing, let us say for example, in a very highly thick bone, probably that time, I might use a 3 mm diameter, that's it. Only these two drills I use. But in cases of conventional, if I want to put a 5 mm diameter implant, at least till 4.8 you have to drill. Come se come. Now just imagine how much penetration diameter you are actually creating in the soft tissue. See, I don't raise the flap. For almost all these 38,000 implants, what I have done, I have never raised a flap. Right? In my life. Because I don't believe in the concept of raising the flap, first of all. Right? So, if you are raising a flap, right, the chances of peri-implantitis is more, bone loss is more. So if from today onwards start practicing, if you are raising a flap, please stop raising the flap. कुछ भी नहीं होगा. It's very easy to actually do without raising the flap. Okay. So next, what is the third reason for doing, means for getting a peri-implantitis? There is a third reason also. Pardon sir?
Movement of the abutment.
Movement of the abutment. Yeah, means not exactly. The loading surface is much closer actually, right? Now, the load bearing area, what I mean to say is load bearing area is very far actually from the load affected area. Understood? Means, now, can I draw on this, Dr.?
Yeah, sir. Just a second, sir.
Yeah. change the color. Up. Right. Now these two scenarios we'll see. Okay. Now they're not tooth, by the way. They're actually bone surface. I'm not a good artist. Please kindly excuse me for that. Now, if you see, right, the conventional implant, right, it is something like this. Till here only in the alveolar bone, you get an abutment over this, and then you get a tooth over this, right? But if you see a basal implant, right, let us say this is your abutment, right, this long shaft, right, and then you have the engaging surface somewhere here, right? So what I was talking about is the load bearing, means the load bearing area is here only, no? Right? The distance actually from the load, this is the load. This is the load, right? Now here if you see, now here also this is the load, right? Now if you see the distance, which is farther, this is the load bearing area, LBA, load bearing area, right? So which is the farthest? In cases of basal, right? Right? Because of this distance also, right? The peri-implantitis chances are 0 or minimal in cases of basal and higher in cases of two-piece implants. Is this clear? Right? Again we'll come back there. Yeah, that is what I was explaining. Now, most of you are interested in this topic, right? See, anybody who wants to practice implants, right, we need to have a very sound anatomical knowledge, and most of the people are scared of doing implants for the same reason. Because the home means, कभी first year में पढ़े थे? चौराशिया, head and neck volume 3, right? First year BDS में पढ़े थे ना, right? Probably surgeons means OMFS people, they would have again, read it in the PG, right? उसके बाद कभी वो बुक खोले भी नहीं ना? Obviously, first year के बाद I don't think so, till I did my PG, even I didn't open that book, right? In practice, we generally don't, right? So obviously, if we need to do anything, we need to have a very sound anatomy of, the bone where actually, we are going to place an implant. Right? Now first and foremost, see, I'm not going to in detail about, anatomy and all. जो practical basal implants के लिए जो ज़रूरत है, that is what I'm going to talk to you. In between, if you have a question or something, please feel free to ask. It's not a big deal, right? So first and foremost, now if you see the anatomy of the maxilla, right? Now the most anteriormost point is the ANS, right? Right here. Anteronasal spine, right? Now very thick cortical bone, right? Now sometimes, now why I am talking about this particular thing is, sometimes you get, in the cases of central incisor or lateral incisor, right? Buccal cortical plate sometimes is concave. Notice? Right? It's concave in shape. So putting a conventional or sometimes even a basal implants is not easy. Chances of perforation are more. Right or wrong? Chances of perforation of the implant. नहीं कर सकते ना मैं. It's okay. Thank you. Right? You understand what I am saying? Right? So whenever there is this concavity, right? I know we can place this palatally. Right? We can actually place this palatally, right? But sometimes there is too thin of a bone, right? It's not easy to place palatally also, right? That times you can actually engage from the anterior nasal spine. You can actually put an implant into that diagonally, and we regularly do this, right? Let us say sometimes there is a cyst in the central incisor or the lateral incisor area. There is a cystic cavity, right? It's not easy to place any implant first of all, right? Similarly, again you can use AMS because it has a very good thick optical bone, right? The only thing is that you need to know the direction in which you have to put, right? So you have to actually go from here to there, like this you have to go, in a diagonal direction. We're doing the hands-on, no? In the afternoon, right? You got the models, no? Yeah. So while doing that, I'll show you how the direction. Means I'll just show you, you have to do it. Okay? So how actually you can actually come out from here. Right? Nothing will happen if you actually come out from here. It's only a 2 mm small bleeding point will be there. Just put a cotton, it will stop. Don't be scared of the blood. First thing, if you want to be successful in surgery or in cases of implants or whatever it is, don't never be scared of blood. Right? Let it bleed, nothing will happen. Right? So, what will happen? So you need to approach from a lateral aspect. Like this you have to go. You cannot go straight. Shouldn't also. Because that will be a very anesthetic look. Right? So if you go from diagonal, so the advantages of single pieces implant is what? Even if you go diagonal, you can bend the abutment in whatever direction you want to. And don't worry, they don't break. They will not break. Right? So aramse you can bend them nicely and then you can give a crown over it. Right? So now, the second area that is of most important for us in doing a basal implants is what is the canine fossa region, this triangle chunk of bone anterior to the sinus. Right? This entire area, even you can actually put in the nasal floor also. You have a very good bone there also, in the nasal floor area. Right? You have a very good cortical bone there, right? The third area is canine fossa region, right? The triangle chunk of bone, no any vital structure there. Aramse you can put a 21 mm implant there. 21 or sometimes 24 also, length. Right? So this entire bone you can use actually. This entire bone you can use for putting in different directions. Let us say for example you want to put a lateral. So you can put it like this. You can do canine like this. For the two premolars also you can do view like this. From distal to mesial direction. Basically like this. You can give implants like this also. Right? And then bend them again parallel. See, more parallelism is actually not required actually in cases of basal implants. Mere parallelism is enough. Not like conventional where exactly, you need to have parallelism and all. Because these are all isoelastic. The implants are all isoelastic implants. Right? So, what is the next area that is more important and most of the people are scared, right, is the sinus. Right? There is actually nothing to be scared of the sinus. Right? Now, today I am going to tell you, probably you would have read it in your previous, in the first year, but as I told you, you would have already forgotten. Right? What is the shape of the sinus?
Pyramid is
A lot of you know this, right? Pyramid. Right? Where is the apex of the pyramid?
So it's a molar, premolar to
Apex. I told you, interactive, no? Let us be interactive. Okay? Now what is the apex of the pyramid? Where does it lie? Huh?
towards the geometric process.
You are answering, man. I know surgeons will tell. Towards the zygoma. Where is the base? Towards nasal floor. Right? So basically, it is towards here. Right? Is the apex. Here is the base. Right? Here is the floor. That is the roof. Okay? Now, here is a tricky part. Now, when you know that this is pyramidal in structure, just go into sort of visualization. Surgery is all about visualization. Because you cannot cut open the patient and see, no? Right? So whatever it is, we have to visualize. Right? Means already in anatomy, if you would have done all this, in the dissection classes, if you would have done this, it would have been easy. That time we didn't do. Right? So, Now imagine, now this is the apex of the pyramid, now this is the base, right? Now it means what? It is not lying down like this. Zygoma is superiorly placed, right? Nasal floor is inferiorly placed, right? So, now the question is, if it is traversing like this direction, what about all this area? Do you think it is empty lying space? What is that area totally? It's covered with bone only, no? You got the point now?
Yes.
Right? It's basically traveling like this, right? It's traveling like this. Right or wrong? Point 1. Because from inferior to superior direction it is traveling, right? But when it is traveling and converging at a point, they are not parallel. If it's a pyramid, they have to converge at some point, right? If they are converging means what? This entire area, what is lying down there? Bone, no. So you can use that bone to place an implant. Why you have to go straight? It means what? Direction of the placement of an implant should be palatal in the molar region. Clear? You understood now? Right? So once you put it palatal direction, again you can always bend the implant, bend the abutment in whatever direction you want to. Got it? Right? So remember this point. So whenever you see an OPG and you see like this, that sinus wall, don't immediately panic and say, oh my God, I can't put an implant here. No, you can. Remember this. Right? And if you actually go more posterior, this entire area you are seeing, no? This entire area inside, I'm talking about inside. This is the posterior wall of the sinus. You have a very, very good cortical bone there. Don't be hell-bent upon putting a pterygoid implant. It's not mandatory in every case that you need to put a pterygoid implant. No. With a very good angulation, you can actually put an implant in the posterior wall of the sinus. In the OPG next, in the coming pictures, I'll show you in the OPG where you can actually, if you see an OPG, you can easily say that, yeah, this is posterior wall of the sinus. You will not get much bleeding also there. Let us say, if you perforate sinus, what is going to happen? Nothing.
Hello.
Right? It will just close on its own. Lot of times we put plates into the sinus only. Don't we, surgeon?
Yes, sir.
कुछ हो गया क्या उससे? अभी तक तो कुछ नहीं हुआ. When you are putting stainless steel only, do you think titanium is more biocompatible than stainless steel plates? No? Right or wrong? Right? So, posterior wall of the sinus is a very, very good area where you can actually place 2 implants. Instead of pterygoid 2, you can actually place 2 implants, that too 18 to 20 mm implants in the posterior wall of the sinus. It's very easy. Okay? Now, as you go more posterior, right, what you have is these brown structures is there, they are the pterygoid plates. They are the pterygoid plates. Okay? Now, how these pterygoid plates are there? Right? How can you actually, can you feel them first of all? With your bare hands in the patient's mouth. Can we feel them? We can't, right? At least not lateral pterygoid. We can actually feel slight part of medial pterygoid. Right? Now, if at all, you can place your own finger into your own palate now. Right? Just put it from the second molar region. Just keep going posteriorly. Right? You will first feel structure of this one, pterygoid hamulus. Once you reach the soft tissue area, soft palatal area, you will feel the structure of pterygoid hamulus. This one. That is one landmark. If you want to put a pterygoid implant. Right? Try it. If not now, in the break, you can actually put your own finger inside and try it. Right? Just put it inside. You will feel the pterygoid hamlet. Right? So what you have to do once you feel the pterygoid hamlet, right? Now rotate your finger towards the lateral aspect, towards the buccal aspect. Like this. Clear? Now let us say this is a pterygoid hamlet, right? I am passing my finger like this in the palate. I felt this structure, right? So immediately turn your finger like this, slightly, right? And just go 3 to 4 mm superior direction. You will actually touch the medial pterygoid. But that is not the area where you have to put implant. Right? यहाँ से little lateral direction you have to actually go. Pterygoid implant is actually not put into the pterygoid bone. It is actually put into the tuberosity and the pterygoid junction. Right? Because if you go too medial, you will go and hit the medial pterygoid plate. Right? So what is the structure that arises from the medial pterygoid plate? Medial pterygoid muscle. Right? See, how do you know that you have touched a muscle? More bleeding. Any muscle you touch, it will bleed heavily. Right? Immediately you will see ecchymosis or hematoma in the soft palate. Remember this. Right? Or if you go too laterally, what will happen? If you go too lateral means too much buccal is there. Right? So what is the more important structure that is there? Pterygoid venous plexus. Heard this? Pterygoid venous plexus. Right? So next, actually it will come there only. See now. See the style means pterygoid thing here. See here? Now, what you need to understand is pterygoid plates are not actually attached in line with the arc of the maxilla. They are actually medially attached. Now let us say my hand, right? This is maxilla, right? My hand is maxilla. Now these two are the pterygoid plates, right? They are not actually attached like this. They are actually attached like this. Now you got the point? They are actually attached like this. They are not in straight line with the maxillary arch. They are actually attached at an angle. So, when you are actually giving a pterygoid implant, you need to follow that angle. So, you need to approach it from a buccal aspect and go towards the palate. And superior direction of 45 degrees. Now, why it is superior direction 45 degrees? Now, doctor, can I see here again diagram?
Yeah, please. You want to draw?
Yeah.
You can draw on this slide also.
Achha.
Just touch the pen. You will be able to draw anywhere.
Achha, ठीक है, no problem. I'll just draw it there. Okay. Now let us say this is a maxilla. Okay. Now pterygoid implant, not implants. Pterygoid plates are actually attached at a superior level to the tuberosity. So roughly somewhere here your tuberosity will come. Pterygoid plates will come. So if I need to approach this junction, right? This is the pterygomaxillary junction, right? This one. This is the pterygomaxillary junction. Now if I need to put an implant here, you understood now? It should be around 35 to 45 degrees it should be. That is the angle I wanted you to know. Right? In an young individual. Now let us say if you are doing it in a let me just delete this. Now if you are doing actually in cases of 70-year-old adult or osteoporotic patient basically. Right? So what will happen? Once the maxilla resorbs more, relatively the junction actually comes down. So what will happen? It will be somewhere like this. It will be somewhat like this, not at a superior position. So you need to see the age of the patient also. So that is the reason I say to feel it with the finger in any patient. Once you feel it, no, whatever the age it might be, sometimes 70-year-old also will have a very good bone. Not much of resorption will be there. So it's always judge it clinically rather than radiologically. In these cases, right, you need not go too much of angulation, 35 to 45 degrees. Only 15 to 20 degrees is also more than enough. Mostly 15 to 20 degrees. In these cases, let us say, if you do too much of 35 to 40 degrees angulation like this, you will go like this. You will actually not go into pterygoid. You will actually go into pterygomaxillary fissure. TMF, right? You will actually go into pterygomaxillary fissure, which actually houses a branch of a trigeminal nerve. Right? You remember in the OPG, you will find a small space like this. If you see, radiologist, I will show you the OPG. Right? That is a pterygomaxillary fissure. Right? So in that area, if you actually penetrate with your drill, you will be actually touching the branch of a trigeminal nerve. Hell lot of a painful for the patient. The moment he will just open the mouth, he will feel shock sensation every time he opens the mouth. So be careful. So judge just that, what is the ridge you have. Right? The safest, that is why I said safest. If you are not confident about pterygoid, it's okay. Put it in the posterior wall of the sinus. No vital, not major structures are there. Happily you can do that.
So there is an artery.
Maxillary artery. But that is too medial. Right? It goes medial to the condyle. Pterygomaxillary fissure जो है ना, वहाँ पे आपको दिख रहा है ना अभी. You are seeing it here, no? Maxillary artery. I'll just show you. Let me do this. Yes. Now, this is a maxillary artery, right? This is a pterygomaxillary fissure here. But you will not get a main branch of maxillary artery here. You will only get its branches. But that is actually more medial. You will not encounter that. Even if you encounter, little bleeding will be there, you have to just arrest that. Right? Now let us say if you actually accidentally to go too lateral and you touch the pterygoid venous plexus. Again, same bleeding. Right? So cold compression. But here you have to be a little careful when you are actually dealing with the pterygoid venous plexus. Why? Because, see here, this one, right? Now if you see here, there are three little fellows here. Three small fellows actually dangling there. Right? They are the emissary veins which connect to the cavernous sinus in the midbrain. Right? The only issue with these three fellows, right? They don't have valves. Normally the venous blood flow, they have a valves, right? So it prevents the backflow. Right? But these fellows, they don't have valves. They come and go at will. So if you damage the pterygoid venous plexus, the chances of developing a meningitis will be more. In the midbrain, infection will be more. So if you come to know that probably you would have damaged pterygoid, means you have disturbed it, immediately put the patient on high dose of antibiotics. Okay? So these things very rarely happen, don't panic. Actually they happen very rarely. If you follow the principle, not too medial, not too lateral. Right? ज़्यादा middle नहीं जाना है, ज़्यादा lateral नहीं जाना है. ज़्यादा middle गए तो क्या होगा? You will touch the middle pterygoid. अगर ज़्यादा lateral गए तो क्या होगा? Venous plexus. So बीच का रास्ता लेना है. You have to just take the middle way. Clear? Right? So next, that is about the anatomy of the maxilla. Any questions? Any doubts you have in the maxillary? See, I have touched only the parts that are required only for the implant placement and all. We did not go in detail about it, right? So now coming to the mandible, right? Not much actually to see in the mandible. We don't require this masseteric and all this stuff basically, right? Now, we know that external oblique ridge, internal oblique ridge, all these things we know, right? But you tell me, one small practical tip I will give you, right? Can anybody say, let us say a patient walks into you in a clinic, right? Edentulous, right? 65 to 70-year-old edentulous patient, long-standing edentulism is there, right? Now you have to do a full mouth implants. Where will you decide that this is the area of second molar? Because you have to put an implant at the second molar region. How will you decide? Because a lot of cases I have seen people putting at retromolar region and saying this is the second or first molar region. होगा ये confusion definitely होगा 100%. So can you tell me a practical tip that by conviction this is the second molar region? Anybody?
Mental foramen is a distance.
मेंटल फोरामन दिखेगा ही नहीं ना बाहर आपको प्रैक्टिकली. एक्सरे में दिखेगा सब कुछ, बट क्लिनिकली आपको मेंटल फोरामन एरिया ठीक है. आप मेंटल फोरामन एरिया कहाँ पे बताइए मेरे को? क्लिनिकली, नॉट इन एन एक्सरे, क्लिनिकली. By looking just clinically in the patient's mouth, you should say, boss, this is a mental foramen. If you want, cut it open. I will show you mental foramen.
First premolar, second premolar.
दांत ही नहीं है. I told you, no? Corner of the mouth तो नहीं होगा. Canine से.
Yeah, it's very difficult. Like oblique ridge, can feel the oblique ridge for the second molar.
Perfect. Perfect. Bang on. Right? So feel for the oblique ridge. Wherever the oblique ridge ends, that is your second molar region. External oblique ridge is there, no?
Yeah.
Right? Wherever it ends is the second molar region. Wherever the buccal frenum is there is the mental foramen region. We always focus only on the labial frenum. We never focus on the buccal frenum. Buccal frenum है ना? Right? जहां पे बकल फ्रीडम अटैचमेंट होता है ना, वहीं पे मेंटल फोरामेन होता है. Right? These are all small practical things, we generally tend to actually ignore. Clear? Right? So these are the things you should actually remember. Right? And then as you come more anteriorly, right? No major any anatomical structures. If you see labially I am talking about, or buccal. Right? These two things are only you have to remember. Right? When you come lingually, right? When you go lingually, right? Once the mandibular nerve divides into inferior and the lingual nerve. So the inferior nerve enters into the foramen, and the lingual nerve actually passes lingual to the third molar, obviously, right? And then traverses anteriorly and then ends into the anterior 2/3 of the tongue. So basically the lingual nerve supplies only the anterior 2/3 of the tongue. Right? But the only issue is you should know where actually the lingual nerve travels. Right? Now there is something called as a lingual groove. Right? There is something actually, it's not clear in this specimen. In the other specimen it is there. Right? It actually travels like this. Approximately 5 millimeters below the ridge. On an average, approximately 5 millimeters below the crystal bone, right? So approximately here, right? It will travel here like this anterior and then innervates into the anterior 2/3 of the tongue at the tip. Okay, on the other side, right? Now here is a tricky thing. When a patient comes edentulous, again long-standing edentulous case, right? Crystal bone loss will be there, no? So now where is the lingual nerve now? It is now relatively more superior. Right or not? So whenever you are doing a case, so make sure that you are not slipping your drill lingually, because you might hurt your lingual nerve. Clear? Right?
मगर सर वो तो सुपीरियर आ जाएगी, जब ड्रिल करते हैं हम ऊपर से नीचे की तरफ जाएंगे.
नीचे की तरफ जाएंगे, इसलिए स्लिप नहीं होगा. skip नहीं होना.
Sleeping.
Okay. Here nerve bypass is done only for inferior alveolar. Don't worry. That how to bypass I'll teach you that. Okay. So next, once you come more anteriorly, region, right? What is this area? Right? Lingual foramens are there here, small, right here, right? That area is the area where the lingual artery from either side come and coalesce. Right? Anterior. Right? So that is the reason when you are actually placing an implant in the anterior region, you actually go from lingual to buccal direction. I mean to say labial direction. Either you go straight or you go in a labial direction. You never come lingual direction. If accidentally you come lingual direction, you might damage lingual artery. Now if you damage an artery, it will bleed like hell. Right? Because venous at least, it's a very smooth flow, like a song. Arterial bleed is like a very fearsome.
Pulse.
It will be pulsating. Right? And even if you want to ligate, it's not easy. Sometimes the arteries withdraw. Arteries have this nature of withdrawing. नाराज हो जाते. चल मैं बात नहीं करता तुमसे. So they'll go back inside. So you have to search for it again. You have to ligate. Right? So simplest thing is to avoid it by just changing the direction. Right? Once you feel with the finger, right? You know where the bone is, where the concavity is. Right? So majorly, most of the time it will be from lingual to the labial direction, or maximum is a straight direction, but it's never like this. Right? शुरू में होता है ये सब. Right? Once you are already placing an implant, there should not be a big problem. There is no difference in technique between this and that. Right? But only few things, technicalities you have to remember, that will come in the surgical part. Okay? So this is about the lingual, the mandible. The next, before placing an implant, we should know the resorption patterns also. Alright? So the maxilla actually resorbs in an upward and an inward direction. Right? Upward and an inward direction. Right? Whereas the mandible resorbs actually in a downward and an outward direction. Downward and an outward direction. So that is the reason most of the edentulous cases, whenever you see them, they actually appear like a pseudo class 3 occlusion. Whenever you ask a patient to bite, no, the mandible actually comes forward. Right? That is because of a pseudo class 3 occlusion. It is not actually a true occlusion basically. So that is the reason whenever you are actually doing a case, you need to take a history properly. You should ask them whether he really was having a skeletal class 3 occlusion, right? Or, probably it was a class 1, right? Because if it is long standing, getting a class 1 occlusion again prosthetic is also very difficult because of a lot of resorption. That time you should at least try for an edge to edge bite, if not a class 1. You understand? Right? So, you should know the resorption pattern, and this is how it looks actually, right? This is how it actually looks. Constricted maxilla, enlarged mandible. That is because of the pattern of the resorption. Right? It looks like a constricted maxilla, no? Like a pediatric maxilla, right? And mandible is enlarged. Okay? So next, selection criteria of the patient, right? So, absolute contraindications are there where you actually shouldn't do any kind of an implant to that matter. Not just only the basal, right? That is radiation therapy. If the patient is on a radiation therapy to the jaws, please don't do any kind of implants. It will definitely fail. Okay? And there is no second thought to that. Okay? And next is what the patients on biphosphonates. Why? They reduce osteonal activity, right? They reduce osteonal activity, so if the patient is on biphosphonates or any anti-cancer drugs, right? Better don't do. Take a proper history, right? This drug you have to remember. And then of course, if there is any active pathology, if the patient is having some angioblastoma or something like that, please don't do. Right? Let that is more priority than an implant. Right? Next, if the patient is on high doses of this drug, please remember this. It is not only just an anti-cancer. Right? It is even given nowadays in patients with psoriasis. Right? So if the patient is having psoriasis, if he is walking into a clinic, please take a proper history, ask him to get his prescription. If you find methotrexate in that, please don't give implant. At least the patient should have stopped taking medication 3 months prior to your appointment. Minimum is what? 3 months. He should have stopped taking the drug 3 months prior to the placement of the implant. Clear? Right? So next, relative contraindications, very severe smoking, diabetes, these are all relative. Uncontrolled, basically. Very relative. They are not absolute contraindications, right? And then indications are what? You can do completely edentulous cases, right? There is no case that you cannot do. Means clinical scenarios I am talking about. You can do completely edentulous, you can do partially edentulous, you can do segmental, you can do single teeth, you can do multiple teeth, you can do a combination of both 2 Ps and basal. Doesn't have a problem. You can actually even do the natural teeth and basal also. You can do the natural teeth and basal implant also. Now let us say for example, 6 and 7 is there.
6 and 7.
Let us say not 6 and 7. 6 is missing.
6 is
5 is there. Okay. 7 is already there. Right. Let us say you don't have a place for 2 implants. You can put only actually for each tooth loss, at least you have placed 2 implants. If you are doing a segmental, right? Now let us say if I want to replace 6. 1 6 or 2 6, whatever it is, right? What you can do is you put 1 implant in the 6 region, you do a crown cutting for 5, give a bridge, not a bridge, basically you do as 1 unit, 2 units there. So 5 and 6. So you can actually, but in cases of 2 pieces implant, you cannot mix the natural teeth, right? But here you can do that. That scenario is very much allowed. Nothing is going to happen. Yeah, your doubt please ask. No problem.
7 is present or missing?
7 is there.
7.
You can include 7 also. Or I am just giving an example. You can give 1 implant here, include 7 into the bridge. Leave the 5. Right? 1 crown on this implant, 1 crown on the other implant. Means both have to be joined, obviously. Right? If you can give 5 and 6 or 6 and 7. Let us say you don't have 7.
Yes, 7 and 8.
Right? 7 नहीं है तो क्या करना है? वहाँ पे भी 2 implant डाल दो. Then include 5, 6, 7. Include the natural teeth. That is what I am saying. If you cannot place more number of implants, what's the issue? Right? So this is what you can do.
और single tooth replacement भी 72 hours में रहती है.
Within 72 hours, anything. Then that is I said no. There is no choice in that. If it is an extraction case, at least you have to give a temporary. You have to load it. At least temporary तो बनता ही है. You have to give.
सर आपने कहा 6 मिसिंग है तो हम वहाँ प्लान डालेंगे.
एक इम्प्लांट नहीं, एक इम्प्लांट नहीं. Generally, if I want to replace only 6, let us say, generally 2 implants I have to give. Basal. It will give a proper support. Okay. Now I have let us say I have placed only for 1 implant there. So I put 1 implant there. I take support from 5. I will include it in the bridge.
सर अगर 6 मिसिंग है तो वहाँ पे हमने 2 बेसल इम्प्लांट्स डाल दो.
बस है उसका अकेले खाली only 1 कैप. No need of taking support from either adjacent. If you have a place for 2 implants, na, that is what your question is.
तो 2 डल जाएंगे.
हाँ आराम से लग जाएगा 2 वहाँ पे. Generally if you that much space then
तो क्यों 2 क्यों डाल दिए?
that give more stability because we are using thin diameter implants. No, only 3.5 mm we use generally. Right?
So one implant plus one
Natural tooth.
one
That is what I am saying. One implant plus natural tooth you can do. If you have place for 2 implants, put 2 implants. Right? Or what you can do, you can put only one implant of wide diameter, 5.5 mm. You can. I'm just saying you can include. It's not mandatory all the time. There is no harm if you include a natural tooth. That's what my whole point is. But in cases of 2-piece implant, you cannot include. No. Like this. Okay? Right? So any scenario, clinical scenario, basically is indicated for a basal implant. With a very good success rate. Yeah.
The cases of fungal osteomyelitis, how much time?
Cases of fungal osteomyelitis, right? Now let us say, for example, what exactly you mean? What did you do there in that scenario?
So we debride the tissue, debride and all the special way should be.
Debride and tissue is there, no? But do you have a tertiary bone to take again? Right or wrong? Now let us say, debridement se nahi hoga na. Generally, if you are having, you will do a maxillectomy or something like that. No, if it is a fungal, you can't take chances only with debridement.
So all the bones should be removed.
That is what I am saying. If you remove the entire bone, then what is the other bone left for you? Zygoma is there, pterygoid is there, nasal bone is there. Even you can take the root of the nose, labella. I have done. I have put 2 implants here. In cases of maxillectomy, total maxillectomy. Because of COVID,
Yes, sir.
right? Lot of mucor cases came. Right? So we did a total maxillectomy. What I did? I put 2 zygoma. Sorry, 2 I think. How many? We put 2 na? 2 zygoma, 2 glabella. And then 2 here. We did it. But that is a very tedious process. It's not so easy as I am saying. Right? So that is again the third bone. No. That is the advantage of these implants. Pterygoid is not actually part of maxilla, no? Right? So like that in any scenario you can do. And regarding time period you are asking,
Yes, sir.
right? You have to wait at least for 6 weeks. Why? Again, it might recurrence chances are there, no? Depends on which fungal infection it is first of all. If it is a mucor, right? You have to do, there is no debridement. Always better is ectomy. Right? It's always better. If it is mucor, you can't take chances. Right? If some other fungal infection not rapidly progressing, you can at least give a 6 weeks to 8 weeks time and then you can go ahead. Right? So now retention points in the maxilla, the first crest and the second crest. Right? The first cortical and the second cortical, basically. Right? Now the first cortical basically will be in the crestal bone area, means the here, right? The crestal and the apical, basically. Or buccal and limbo. Right? So first and the second cortex. If you are involving other than maxilla, then it is called tricortical. Like in pterygoid, zygoma, nasal, they are called tricorticals. That is a tricortical. Right? Bicortical means what? In the same bone. Okay? So the nasal spine area, I told you, right? The cortex, within the cortex actually, see this area, this entire area. So very, very good sound bone you will have there. Right? So what I was telling you is, in this picture it's easy to show you. Don't put an implant straight here like this. It's a crime. Okay? Because that is where actually the two halves come and meet. So please don't do that. Okay? If you want to put an implant, come from the lateral aspect and then go inside this like this and you can come out here. It's like this. It's not like this. So you have to go like this. From either side like this. Namaste. So it forms actually a namaste like this. 2 implants. Okay? Like this. And you have a very good retention you get. 11 mm implant will be more than enough. Depending upon from which area you are actually approaching it. If you are actually approaching it from farther area, then 13 to 15 mm implant would be sufficient. Clear? Right? So the next, again I told you, right, from the bone in the nasal bone area, right, you got a lot of cortical bone there also, right, so much of bone is there, right, you can use that bone also, right, little bleed will come, because see, when you are drilling actually, right, you have to go through the second cortex, you cannot stop at the second cortex, remember this. I will show you the process of drilling. When I am showing you the process of drilling, step by step I will explain you what you are going to encounter clinically and what you should do. Right? If you get bleed, nothing will happen. It's just small pinpoint bleeding will be there at 2 mm and nothing. Okay, just for a couple of minutes it will be there. Now, this arrow marks, right? This entire triangle chunk you are seeing here, this one, right? This is the entire posterior wall of the sinus, right? So to approach that area, you can actually just directly go from here to here like this and from here to here like this. Now if you want to go to pterygoid, you have to actually go like this. But this area you can just go straight. That will give you more actually, for the processes it will be more easier. Okay, right? Same thing. The intrasinusal buttresses. This is the hard palate, no? You all know reading OPG, no? Right? So this is the hard palate. This radial opaque structure you are seeing is the hard palate, right? So basically this is your posterior sinus. This triangle I am talking about, radiolucency here. This is the pterygomaxillary fissure. This one, this entire area. So what I was telling you is, if these pterygoid plates basically which are posterior, right? If they are actually resolved, means if the maxilla gets resolved, what will happen now? They are standing at the same level. So don't put it superiorly. So if you do it superiorly and straight, you will actually go somewhere like this here. Right? Your branch of maxillary artery actually little more medial it will be and then it will enter inside. Right? But there is a branch of a trigeminal nerve which is there here. In the gap. Patient will get severe shocking pain whenever he opens the mouth. Right? So that is an indication that you have touched it. Right? So simple is what? Follow the basic, angulation properly, more than enough. That's it. Always put your finger and then just keep palpating it. Okay? So next, this is the tricortical I just mentioned. Pterygoid plate. See here also if you see, this is the arc of the maxilla, but pterygoid plate is somewhere here, right? They are actually located medial, right? So if you want to approach, you have to actually approach from here to here into this junction like this. Okay? Right? So next is a zygomatic bone. One more tricortical is a zygomatic bone. Right now we are not dealing, means today we are not dealing with the zygomatic. Probably in the due course of time when we do another course we will deal with that. Okay? So retention points in the mandible, same, first crest, second crest. Now what I need you to remember is this. Right? Lot of people think, right, that basal bone or cortical bone lies at the base only. This is a very big misconception. Right? I'll just draw here only. I think a switch off for the Doctor. I think its charge is not there. Anyways, I'll show it here on the other screen. So, now see, always remember in either the means in the maxilla or the mandible, right? Now till here, right, generally will be the your cancellous bone, right? Let us say your root, जहाँ तक root है वहाँ तक cancellous bone है, basically, right? Now exactly from root tip, remember this, 3 to 4 mm from the root tip, your actual cortical bone starts. It is not at the means apex. It's not at the base. right? It's not here, not only just this one. It actually goes on increasing in mineralization, that's it. But the actual cortical bone starts 3 to 4 millimeters below the root tip. This is what you have to remember. It means, what I mean to say is, if you are actually putting a bicortical implants, BCS implant, your threads should engage beyond the root tip. Lot of people do a mistake of placing the implant till here only. That is the reason they fail. Dr. Man, we were discussing in the morning, no? Somewhere it got failed in 3 days only.
Yeah.
Right? The reason they fail is because they don't actually engage into the cortex. They actually engaged only into the cancellous bone. And since this works on the principle of fixation, not on integration, you need to fix it into the sound bone rather than into the cancellous bone. Why? Because whenever you tight something, there is a chance of derotation. Accepted? Right or wrong? In cases of two-piece implants also, right? When I actually do an abutment tightening, for a due course of time, what will happen? The abutment will actually become loose. Again, you create a hole or whatever it is saying, you tight the screw. Why it is getting derotated? There is a chance, no, always. Right? So, when the two-piece implant is not fixed below the root tip, at least 3 to 4 mm below, वहाँ से start होता है cortical bone. So I want actually you to go beyond that. That is the reason we use all 16, 18, 20, 21 mm implants. Why? Otherwise I can't take advantage of the cortical bone. No. The only reason a bicortical implant fails is not because of the implant, is because of us. Why? Because we placed it in a wrong position. Simple. So per se, both the implants are the same. Not actually, if you see, not much of a difference in the failure rate also. 95%, 98, 99%. Right or wrong? ज़्यादा difference नहीं है. But if you do a number of implants, so 2-3% is also more. Right? But if you actually ask me, if you really follow the principle, just know what I said, 3 to 4 mm beyond the root tip is the cortical bone where it will start. So उससे और थोड़ा नीचे जाना है your implant.
सर ड्रिल करते हुए ये एक्सरे से पता चलेगा कि कोई और
In the surgical part, I will tell you when you will come to know that. Okay, that will come in the surgical aspect. Drilling में कैसे पता चलता है हमको that I am actually cortical bone में हूँ, where I am, all these things I am going to explain in the surgical part. But just remember this point. The only reason that fails is because they would have placed it in the cancellous bone, not in the cortical bone. And they don't do welding also. वो टाइम पे टॉर्क आएगा आपको. Why? Because you are drilling a 2 mm drill bit, you are putting a 3.5 mm diameter implant. Don't you think the torque will come? No? Anyways. आएगा ना, but बाद में नहीं आएगा ना. It will derotate. You actually forced it. You did not fix it. You understand? Right? So definitely you will get a torque at the initial time. But after 3-4 days you will not get any torque. Yeah? Right? So next, these are the retention points, alveolar crest, basal bone. And now, always remember, whenever you are placing an implant, you should use the bone that is below the oblique line on the buccal aspect here. Right? So your implant should not stop here somewhere above the external oblique ridge. Your implant actually should go beyond it. That this is one more landmark. Lot of people say that it failed because they would have placed it above it. Where actually normal regular implants are put. Right or wrong? Regular implants इसके ऊपर ही रहेंगे ना generally. ये bone use करते हैं ना. But here we have to actually go beyond it. Right? So basically the failure happens because of not placing it in a right position. Okay? So next, when coming to the lingual aspect, always remember, let us say this is a mylohyoid ridge, right? Your mylohyoid muscle is there, so the bone should be beyond the mylohyoid ridge, means below the mylohyoid ridge you have to go and engage, not above it. Right? Your implant always, let us say this is the mylohyoid ridge, your implant should be here, not here. Even if it is external oblique ridge, you should be below, not above. If you are above, what will happen? Fail. वो टाइम पे आएगा आपको टॉर्क. That's what my whole point is. When you put an implant, you will get a torque, but बाद में it will derotate because you did not fix it in a sound mode. Even our mini plates and screws also, they will get loose. Just that we don't open them because we use only monocortical, no? Right or wrong? They also get loose. Right? So, always remember these points. Okay? Now, this is a diagrammatic representation. Basically, all those green areas, basically, all the primary means the engaging areas, retention areas, basically. Okay? Now, this middle point is there, IFR, interforamen region. Wherever you want, you can put an implant without any hassles because there is no vital structure there. Right? Even in cases of mental, in the surgical part, I will explain you, don't worry. We can easily bypass the mental, we can easily bypass the inferior nerve. Nothing to worry, no paresthesia, nothing. Okay? So remember this diagram. Okay? So, number of implants. Right? See, if you are doing a full mouth case, right, means absolutely zero teeth in both maxilla and mandible, right? Minimum number of implants that you have to put in maxilla is 10. This is a minimum. 10 implants in the maxilla, 8 implants in the mandible. If you are doing a full mouth rehabilitation, if you want a good longevity, if you want a good stability, right? So minimum number of implants, basal implants that is required for an edentulous maxilla is 10, for edentulous mandible is 8. So total 18 implants. The more, the merrier. If you want to give more implants, you have a good space, no problem. Even if you can do 12 implants in the upper, 10 implants in the lower, chalega, problem nahi hai. Right? So no problem. You can always give that. Right? How many ever you want. Now, partial edentulous jaws, as I already told you, always remember, it's always one implant more the number of teeth that you require. One implant more than the number of teeth required. Now, let us say if I want to replace 3 teeth, better put 4 implants rather than giving 3 implants. Always, jitne दांत you have to replace them, 1 implant ज़्यादा डालो. 3 teeth के लिए 4 implants डालना है, 4 teeth के लिए 5 implants डालना है. You understood? Okay? In a different direction you can put. Right? It's not that if you don't have space, I have to only go straight. No. You can actually bypass the canine, you can actually bypass the premolar. In different direction you put and then you can actually bend them in a proper direction. Clear? Right? But rule of thumb, always remember for basal, jitne daant you have to replace, it's partially edentulous. Right? One implant more. Simple. Okay? In extraction sockets, single tooth replacement again. If there is no place for 2 implants, let's say central incisor you want to do, 2 implants लगाने के लिए place नहीं है, no problem. Right? If the patient agrees, take the support from the adjacent teeth. Give 1 implant only, take the adjacent teeth support and give 2 crowns. If the patient doesn't accept, no problem, just give a single teeth, okay, single implant. But just give a Maryland kind of a crown. Maryland bridges yaad hai na? With clasp. Wings aata na? Maryland clasp. That kind of a crown you can give. They are not visible, no, parallel side they will be. Like that you can give. Okay? with single implant. That will also prevent derotation and everything. Clear? Understood? Or sir, आपको समझ में आया?
Please repeat the Maryland type of crown.
ना Maryland कैसे रहता है? Basically it's a crown with wings.
Yes, sir, I got it.
Right. So, if the patient is okay, let us say if you have place for 2 implants for central incisor, put 2 implants, give 1 crown, if at all. Right. If you think that there is no space for a second crown, second implant, put single implant. If the patient is okay, take the adjacent teeth support, give 2 crowns. Okay. If the patient says no, I don't want my other tooth to be grinded, give a single implant. Make a crown with the wings, so that wings will engage on the parallel aspect on the other side.
Prevent rotation.
To prevent
To prevent the
derotation.
rotation.
That's it. Simple. It's just like splinting. If at all. Okay. Otherwise, see, if there is a good bone, durability is there, very good. Right? Very good bone. Let us say if the patient is having good bone, put a 2-piece implant. I am not against 2-piece implants. That's what I said. Depending upon the scenario, case scenario. But I am saying, any case you can do basal. Right? Extraction socket, again. I told you, right? First, put the drill. Don't switch on the motor. Just put the drill. Feel the tip of the root tip. Then switch on it. Then go beyond the root tip when you are drilling. I told you, right? 3 to 4 mm below the root tip is the cortical bone. Right? अब ये root tip है. ये drill bit यहाँ तक पहले ऐसे feel the tip of this thing, right? Then switch on the drill. Then go beyond. At least 6-8 mm you have to go. More than that sometimes. I'll tell you in the process of drilling how you can actually make out clinically whether you are in the right place or not. Okay? So next, so we're now coming into the surgical planning, right? So obviously what are the things that are required? Are you tired? Are you okay?
Yes.
Right? Shall we continue the surgical part also?
Yes.
And then we'll give a 10 minutes break and then we'll go into prosthetic aspects. Okay, because this is more important. Because prosthetic aspects and all are almost the same like your own 2-piece implants. ज़्यादा discuss करने की ज़्यादा नहीं है वहाँ पे, right? It will be almost a similar thing only. And you are already practicing dentist, right? So, armamentarium that is helpful, basically clinical photographs. If you have any patient's previous photographs, right, when the teeth were there, when you are doing full mouth rehabilitation, always ask for the previous photograph. If any nice smiling photos are there, right? Based on that, you can make your judgment, right? And next, obviously, X-rays. Don't insist on, if you are doing a basal, don't insist on having a CBCT. Not at all required. Till date, I haven't done a single case using a CBCT for basal implants. Trust me when I say this. Not even a single case I have done using a CBCT. OPG, yes. OPG is more than enough. See, the more that technically you evolve, the more confusion actually it will create. I am not saying they are useless. They are useful. When you want to do a 2-piece implants, please use them. Right? But when you want to do, or if you suspect any kind of pathology there, let us say you find a radio opaque lesion, not even radiolucent, no PG. So whether you want to know it's a cementoma or whether you want to know it is something odontoma, I don't know whatever it is, right? Then you go for a CBCT to examine it, diagnose it, that's it. But per se, for a basal implant, what do you say, Seshu? Do you agree with me with this? Right? I don't think Dr. Seshu has ever used the CBCT for placing, so many implants. How many you would have placed? 10,000? How many?
6 to 7,000.
6 to 7,000 implants. And I have placed almost like 20,000. Right? I have never used. Seriously. Right? But if you have, why I'm saying that don't insist. It's not that it doesn't help or something like that. In some areas, there won't be CBCT first of all. Not every area will have a CBCT machine. And sometimes if the patient goes for CBCT, he will go forever from you.
Very true.
I'm telling you frankly. Right? Forever he will not come back again. Some Tom, Dick and Harry will meet him on the way. कहाँ जा रहे तुम? मैं इसके लिए जा रहा हूँ. अरे आपको पता नहीं है वहाँ पे बहुत बढ़िया करते हाँ चलो जाएंगे. गया. I'm telling you, these things happen. This happened with me also. Right? Don't insist when you actually don't require it. So why? Just to say that I am a very advanced dentist, not required, please. Okay? Clinically, OPG is more than sufficient. If you want a localized, take an IOPA, that is the best thing you can ever do. If you want to give a single implant, for that no need for an OPG, no. You can actually just put an IOPA and then see, RVG is more than enough. Right? So, of course, all these intraoral middle cheek retractor, just to fill up the slide, I have just added on those things. Okay. So, next. Anesthesia, yeah, of course it is safe to do under local anesthesia, but if the patient is having a severe gag sensation, if the patient is having a very severe gag reflex, right, please do under GA. It will be more faster. Or a short GA. Take a half an hour to 40 minutes. See, for putting a 20 implants, maximum time means on practice I am saying. Okay? Maximum 40 minutes mein ho jayega pura. Half an hour to 45 minutes you can finish all the 20 implants. Right? On practice. Initially you might take 2 hours or 2.5 hours, I am not saying that. Right? But once you start putting more number of implants on a regular basis, once you start consulting around, and then you start putting more number of implants, 20 implants will take hardly 40 minutes. Hardly. Right? So for that, more than ketamine, short GA. Just, ask the anesthetist, he will come and give, or take him to the OT, taka, it will be finished. Because you don't require cooperation from the patient. Right? I have done it. 2-3 cases I have done like that. Because if the patient, you put a mouth mirror also, she is doing what you can do? Even if you put mouth mirror also, she is having that gag sensation. So you can't help it in such situation, but you have to rehabilitate. Right or wrong? And what will happen whenever there is a gag sensation, there is a lot of salivation. You have to deal with that also. So instead of that, right, best do under short GA or GA, depending upon how much time you take. Okay? Right? So otherwise, other than that, it's more than safe to do under local anesthesia. Right? And then, what are the blocks basically? For maxilla, trust me, no requirement of any block, give infiltration, only greater palatine and nasopalatine is required, that's it for the block. Otherwise, posterior superior nerve block, middle superior nerve block, zarurat hi nahi hai. Even for pterygoid also, just deposit locally. Local infiltration is more than enough. Even for putting a 24 mm implant. More than enough. Right? Just give infiltrations. Clear? Right? Please, no requirement of all this complicated thing. Infraorbital block. अरे मेरे को एक बात बोलो, infraorbital block, where does it supply? Right? Till the area of the nose, right? How it is related to the teeth? Right? So it's not required actually. Right? So only infiltrations are more than enough to place an implant. In fact, for mandible also sometimes only infiltration is more than enough. No need of giving block if you ask me. Infiltration से implant लगा सकते हैं. Okay? Right? So, nasopalatine, only remember, see, I am not going into how to give nasopalatine block and all these things. Okay? But nasopalatine, always remember, obviously, don't put it perpendicular to that needle, otherwise you will get a lot of resistance, your thumb will go, right? Best is to insert, now let us say this is incisive papilla, a lot of people give like this, no? Don't give like this, put it parallelly and just go inside, you will nicely enter into the foramen, just deposit 1 drop or 2 drops of solution, more than enough to block that entire area. Simple. Even greater pattern, 0.5 cc is more than enough. Not 1 cc, 1.5 cc. 0.5 cc is more than enough to block it. Okay? Right? So, that is about the maxillary blocks. Mandibular, of course, inferior alveolar block and the long buccal and the lingual nerve. Mental nerve block actually is not required. Right? Because it supplies only the chin area, no? Lower lip and the chin area. Actually, there is no point in giving it. Right? If the patient is saying, and all, I am getting pain here and all, then you can give. Otherwise, not lower lip. Simple. Okay? So, more than enough is what inferior alveolar nerve block, long buccal and the lingual nerve block. Right? And lot of you might be giving, see, as a senior practitioner, as a senior means OMFS, I am just suggesting you, right, that whenever you are giving inferior alveolar nerve block, this any course, I just go on telling this, because I have seen people, do this mistake again and again, right? Now, whenever you are giving inferior alveolar nerve block, sir, and lingual nerve block, right? So, what is the direction of your needle? You come from opposite side, go inside, aspirate, deposit, again come on to the buccal side, go inside, aspirate, for lingual nerve block, right? This is a wrong way of doing it. Just because our seniors taught it like that, we have been doing it, it is crap. I am sorry to use this word. Please don't do it. I have seen cases where people reinsert the needle and broken it, and I have just, the needle was there, we had to open it surgically, we have to remove it. That case is more than enough to finish your career. I am not scaring you. Right? When just the anatomy first. Right? Now, mandibular nerve, my arm is mandibular nerve. Right? Now this is inferior, this is lingual nerve. Right? Now it has entered now inside. I have come here. Right? Lingula is there. I have touched it, aspirated, given it. Now you tell me, why should I come back and go like this? Lingual nerve is only just slightly anteromedial, no? So, the same needle in the same direction, just to withdraw another 2 mm and deposit, your lingual nerve is blocked. So, what is the point that you come into the buccal side and go here, again you are going there only? You understand what my whole point is? Right? Just come here, touch the lingula from the opposite side, right? And then with deposit, withdraw the needle 2-3 mm, again deposit, over your lingual nerve is blocked. Please, from today, whether you follow it or not, again it's up to you, right? It's up to you. All the courses whatever I have taken, I tell this point. It makes sense, right? It's just anteromedial, no? So what is the point in turning the needle? It's not about your mistake. If there is a manufacturer defect, there is a small kink on the needle. When you rotated it and you have again inserted it, when it is broke. That's it. Right? You have to again call a surgeon. Sometimes you have to call a ENT surgeon also. See, once posterior mandible, the chances it can go anywhere. Why they say that, Ludwig's angina is very dangerous when it comes in the posterior retromolar region? Why any cancer when it comes in the RPM is very dangerous? Right? The spread is very rapid and it can go in any direction. Same way the needle can go in any direction. you can't have control on it. Right? Anything beyond RTM means retromolar trigon. Very dangerous, right? Prognosis is also very poor. If you see in cases of oncology also. Okay? So, if you can follow, please follow. Otherwise, again, it's up to you. Right? Great. So now, what is the supporting polygon concept? See, basically supporting polygon concept, it is there in prosthetics also, you would have heard, for a better success of the implant processes. Right? There are a few areas where actually you mandatorily have to put an implant, right, to finish the polygon. Right? Those two areas are the canine and the second molar region. Canine and the second molar region, these two are the mandatory areas where you are supposed to place an implant. Without putting an implant in those areas, it will fail. Clear? Right? Because you have to put, if you want to finish the polygon, no? So you have to put that area.
I'll add a blank
Slide, no? Blank slide. I just draw and show it to you. Okay?
This must be this slide.
Shall we click on play here?
Yeah, play. Right. You can remove the wires. 13% will last.
Okay. So, right. So in the maxilla or the mandible, right, the canine and the second molar region are the more important areas where you are supposed to put an implant. Right? They're mandatory. Right? Now sometimes, right, there is lack of total bone, right? Or let us say, you don't have any bone or anything there in cases of second molar region. In that cases, you are actually supposed to put pterygoid implants. At least if you have posterior wall of the sinus, thick bone, at least 2 implants in that region, right? Or into the pterygoid bone. At least put 2 implants into the pterygoid bone like this. Okay? So this will actually finish the compensatory mechanism and then this will finish the polygon. Clear? Now you have seen that? See when, see, canine region is there, second molar region is there. If you have a sound bone, at least if there is a 6 mm or a 5 mm bone, let us say for example visibly, right, then you can put a wide diameter implant in that. Right? These are the mandatory areas where if you want a proper stability of the processes, these are the areas where you ought to put an implant. Otherwise it will not be successful. Wherever you put, if you miss these areas, it will not be successful. Okay, these are like a pillar stones. Right. So, if by chance you are not able to place an implant in the second molar region, right? For that reason only, to compensate or to finish this polygon, right? For that reason only, you actually put 2 pterygoids. These 2. right? Or if there is lack of space in the pterygoid only, let us say for example, we can put one pterygoid implant and one posterior wall of the sinus implant. Don't worry about the direction. Because if you are actually putting an implant in the pterygoid area, you are actually not giving a 8 molar or say 8 or 7. Based on that, we are not giving anything there. The pterygoids are implants basically put for axial support, not for vertical support. Right? From the lateral forces, not for the vertical forces. Pterygoid implants actually serve that purpose. So don't worry about the direction. अरे मैं 45 डिग्रीज पे ऐसे डाला, ऐसे कैसे वहां पे दांत नहीं आएगा. There will be just a metal cover on it, that's it. There won't be any kind of teeth coming up there. Right? I'll tell you how. I'll just redraw that so that the confusion will go away. 1 second.
सर मैंडिबल में भी सेम पोजीशन रहेगी.
मैंडिबल में मिल जाएगा आपको उतना रिसेशन और वहां पे तो ट्राइकॉटिकली नहीं है ना. यू कैन डू, यू हैव टू डू ओनली बाइकॉटिकल. बट एटलीस्ट यू हैव टू, यू कैन एक्चुअली टेक फ्रॉम द लिंगुअल बोन. नाउ इन दिस एरिया, राइट, so what I was telling you is, okay, now this is a second molar region, right? So when I am putting two pterygoids like this in this direction, right, now you might be wondering, wahan pe to means it's not even, it's at a 45 degrees angulation, right? So what I was telling is, yahan pe there won't be any teeth here. Let us say all these implants are here, one more implant here, one more implant here, one more implant here. All the teeth will come over this only, but here the metal, actually the framework only will be on this. There won't be any teeth. Only the metal framework is actually designed onto that. So don't worry about the direction. If you get a very good torque, no, if you want you can bend that also. But sometimes because of the nature of the pterygoid junction, it's not so sound enough that if you bend, sometimes you might fracture it also. Better leave it like that. Nothing will happen. Clear? You understood now? Right? I'm just wiping off this because next is more important now. I think power is not good, no?
I will go ahead. We have solar. This whole building is on solar energy.
Yeah, it's coming, it's coming. So entire building is solar, huh? Okay. So now coming to the drill sequence, right? This is very important. This is what, once you know this, it's very easy to put an implant in cases of basic, right? See, the drills that we use here is a lance drills basically, right? In cases of two-piece implants, we generally have the spiral drills basically, right? Or in cases of surgeries also we use a spiral drill basically. Here, what we use is called as a lance drill, lancelet basically, right? Lancelot drills, right? Now what is the speciality of this is, they are actually triangle in shape basically. The only sharp is the tip, right? And the major advantage is what? Whenever you come near a soft tissue structure, let us say a nerve, right? Or a blood vessel, right? If I am not talking about the tip, the sides of the drill, right? They generally deflect it away rather than entangling into it, right? But if you take any other drill bits, or spiral drill bits, right? If you actually come across a blood vessel or something like, or even to a cheek also, let us say for example, or you put a cotton roll also, what will happen? Immediately it will entangle itself, encircle like this, right? But this one, what it will do, it will deflect it away. This we have practically tried, that's why I am saying, right? We have practically done it. So it will deflect only, it will not get entangled like this. So the damage to the soft tissue structure is very, very minimal, or I can say zero. And these are the only drills that we use. Right? Now, whenever you are drilling, right? Again, whether you raise a flap or you don't raise a flap is totally up to you. Again I am saying. But my suggestion, personal suggestion would be, please don't raise a flap. At least for basal, not required at all. You would have seen YouTube videos where they would have raised the distal flap also to put pterygoid implant. Please, not required. Not at all required. Unnecessary disturbance to you, unnecessary disturbance to the patient also. Now, you might ask, sir, if there is a knife edge ridge, then I need to raise a flap? No? Don't worry. Approach it from the lateral aspect. You understand? If this is a knife edge ridge, don't put it on the ridge. Slightly buckle से approach करना है और lingual जाना है. बस simple है.
Light है, light.
Huh? Somebody saying something?
Bone. Talking about bone.
It's a phone. You understood now? If there is a knife edge ridge, there is no point actually, open the flap, उसको, अच्छा flat करना है, then I will drill. Simplest thing is what? Just come 1 mm lateral and then drill it. Simple.
Lateral means like bucket.
Bucket.
In mandible?
Mandible also. Bucket lingual. Mostly वहीं पे होगा.
Maxilla palatal.
Maxilla palatal. Simple. Okay. So from palatal approach you can do. From palate actually you can do. If you have a knife edge ridge. 1 mm, that's it. To avoid that slippage. Clear? Right? Now, what is this? How to drill first of all. Right? So whenever you are drilling, right, always remember, right, these 2 fingers, thumb and the index, right? These 2 fingers are your main armament area. There is nothing beyond these 2 fingers, right? So always hold the maxilla or the mandible, right, with these 2 fingers. First palpate the contour of the maxilla, whether it is concave or convex, whatever it is, right? So based on that, your direction of drilling should be there, right? And why am I asking you to develop this tactile perception or tactile sensitivity with these 2 fingers is, let us say for example, now I am drilling, right? If you are going too palatal, what will happen? The rate of vibration actually onto your thumb will increase. So immediately what do? You actually don't go too palatal, you make it more straight. It means what? That if the rate of vibration is increasing or heat is generating more, it means what? You are very close to the palatal perforation. Or vice versa. If it is too much labial, you will feel more sensation on the labial aspect. It means what? You are going to perforate here on the labial side, right? So always remember, before drilling, put these 2 fingers. Please. Okay? And now, in cases of drilling, always remember, you have to first, without any switching on your foot pedal, right? First penetrate the gingiva, touch the sound bone with the drill, rest it on that there, feel the bone there, then switch it on. Never first run the drill, then put it on the gingiva, because utna stability nahi aayega. Clear? Right? So that is one thing. Now second thing, when you are drilling, how to know where you are. Whether you are in the first cortex, whether you are in the cancellous bone, whether you are in the second cortex, or whether you are out of the second cortex. Now this is what, let it come, I will draw it and show it to you. Okay? So now, remember R1, D1, R2, D2. I am going to explain what is this. Okay? R1, D1, okay? R2, D2. Let this come, I will draw it and show it. So and then after that, you will not have any confusion in drilling now. Okay? Now, okay, all of you focus there only. I am drawing it, okay. Now this is the bone where I am going to drill. Okay. Now this is my drill bit. Okay. Now first thing what I said, R1 means what? Resistance 1. The first resistance you actually feel is on the crest. Alright? Now remember, okay, first resistance when means you have touched it, no? When you actually penetrate the soft tissue gingiva, right? Now what will happen? You will get resistance, that is R1. Once you enter into the cancellous bone, you will get first dip, that is called as a D1. What is that? D1. Now, most of the people stop their drilling here. The reason, the failure that happens is because most of the people stop the drilling at the area of D1 and put a shorter length implant. That is the reason it fails. Basals. I am talking about basal. Right? Don't stop. Continue drilling. Right? Now what will happen? I told you, right? 3 to 4 mm below the cancellous bone or the tip of the root, your cortical bone will start. Now denser bone will start from here. Again you will start getting resistance, that is called R2. Okay? The second resistance you will get, that is called as a R2. Right? Now that will continue till the basal bone. Right? Once you are out of the basal bone, that is called as a D2, that is dip 2. So I want you to drill till the area of dip 2. I don't want you to stop neither at D1 or at R2. I want you to drill till D2. Means, let us say for example, if I am actually drilling in the posterior mandible, right? Posterior mandible I am drilling. I should actually come out lingually. Not onto the soft tissue. But you have a bone there, right, inside. Right? You will feel the dip, no, immediately once you come out of the cortical plate. Right? Immediately stop drilling. Why I am telling you, you should stop at D2 only is because that is how you will come to know the exact length of the mandible that is available. Based on that only you have to select your implant. Not based on the radiograph. That is why I said I don't require a CBCT. Got it clear? Now let us say for example, now the total length of the drill bit is 24 mm. Okay? Now let us say, you should know, no? The drill bit also you should know. The lengths, right? The total length is 24 mm. Right? Now, let us say for example, sir, you get a second dip at 20 mm. You got a second dip at 20 mm. So what is the length of the implant that you are going to place? Why 18? Your answer is correct. But the reason why? Because you have to minus the gingival width, no? Right or no? You have to minus the gingival width, no? So taking on average of gingival width as 2 mm, if I am getting a second dip at 20 mm, so I will be selecting an 18 mm implant. It will not go out. Dip is what I just exited and came out. My drill bit is only just exited. Right or no? Right. So don't worry, the patient will not be able to feel with his tongue like this. No, because you are below the mylohyoid. Now remember this point again. That is why I said bone caudal to the mylohyoid ridge. So if you are below the muscle, do you think your tongue can go and feel below? Nothing. And there won't be any soft tissue damage also with the implant. It's perfectly biocompatible. Nothing will happen. Clear? Same in cases of anterior mandible also. Right? If at all you don't want that small penetration outside also, you can put a 16 implant, no problem. Another 2 but still you are in the cortical bone only. Understood? Right? So based on your drilling, your implant length is decided, not based on your X-ray. X-ray can actually give you only a rough estimate of the implant that we are going to put. So based on an OPG, I can simply say, okay, I will be requiring 10 18 implants, another 4 15 like this I can just generalizely say. But when I drill and when I know all this R1, D1, R2, D2. So first time when you are doing basal, no, please repeat this mantra, right? R1, R1. Once you get the dip, yes, D1 has come. Again keep going. Again you will definitely get resistance. Then immediately you say yes, R2, tap, dip. I achieved D2. Now let me place an implant. Till you get D2, please for God's sake don't put implant. It will fail. Most of the failures happen because people stop near D1. Most of the implants become loose because they did not place it in the cortical bone. They placed it in the loose alveolar bone and expect miracles to happen, which is never going to happen. Clear? Right? Any questions here?
Sir, what is
Any confusion? Sir?
So what, like, we have done a lot of implants, but still I'm always scared of that lingual artery.
I'm coming there, sir. Lingual nerve or lingual artery?
Lingual artery, sir.
Lingual artery क्यों आएगा आपको वहाँ पे?
Base of the mandible.
No, नहीं आएगा lingual artery. Lingual artery actually is in slightly medial. Actually, it's not exactly adjacent to the mandible. It is slightly medial. वहाँ पे आएगा soft tissue. If you raise the tongue and see on the floor of the mouth, no, artery is not visible, okay, but it's slightly medial. It's not lateral.
Okay.
नहीं आएगा. Lingual damage नहीं होगा. ये लिख के ले लीजिए आप. नहीं होगा. Right? But once you get D1, no, please don't continue your drill. Please remove it. This is mandatory. But anyways, even if you want to drill, it won't. Because you are already beyond 24 no? The drill length is only 24 After that you have a stopper there. Anyways you can drill. Right or wrong? Right? So anyways you can drill, no problem. Right? Now, next is what? Any questions here? Any more questions regarding this?
सर लोअर में हम लिंगुअल टू बक्कल जाएंगे ना?
I'm coming there. Next I'm coming there. Okay. Now, your question. Okay. So nerve bypass means what? Avoiding the nerve. Simple. Right? Now, if you see this picture, what exactly it is teaching you? You tell me in this specimen.
From lingual side to buccal side.
Perfect. Right? Right? It means what? In most of the cases, right? If you see, actually, it enters lingually. That is beyond third molar region. Right? But actually, when it crosses the third molar region, no? It is actually more in the buccal direction. There is actually a groove on the buccal cortical plate where the inferior nerve rests and releases its branches which enter into the tooth. Right? That is what you are seeing there. Right? A lot of my surgeons will agree with me. When you did a BSSO, bilateral saxillary split osteotomy, when you actually divided the mandible, where was the nerve? Buccal or lingual?
Mostly on
Agreed? You got a confirmation now? Right? Most of the times, right? Most of the times, the nerve is actually on the buccal aspect. It is not on the lingual. Maximum it will be in the center, but not lingual. ठीक है? तो इसका मतलब क्या होता है? We have to place, or we have to drill an implant in a lingual direction.
Okay.
You understood now?
From buccal towards the
From
lingual.
buccal towards the lingual.
कन्वेंशन का उल्टा हो गया ये.
That is what I am saying. But we are not actually violating any kind of anatomy structure here. You can understand. Right or wrong?
Right.
We are not at all violating any law. But the only thing is that you need to have an open mind to accept things. Because we are not going beyond anything beyond science here. Scientifically I am speaking, right? That is what I am showing you the diagram also here. I am not here to convince anybody to do Basal. I am just trying to say, there is an option that you can do. Right or wrong? Okay? See now, when you actually see in this diagram, right? Now when I said that you have to go below the mylohyoid ridge, right? Agreed? Right? Now how to go below it? Simple. Now you know, see now this is a drill, right? I have put a drills first straight. Right? Now my mylohyoid ridge is here. Right or wrong? But I have to go from buccal to lingual. At the same time I should not penetrate this one, no? Mylohyoid ridge or the muscle. So simple what you have to do. Just put your drill bit exactly 5 to 10 degree angulation. Not more than this. If you give more angulation, you will be superior to the mylohyoid ridge. Right? So when I just give a 5 to 10 degree twist in a lingual direction. So this is straight. Right? Mandible. Just give a 5 to 10 degree angulation. Just keep going, keep going, keep going, keep going, keep going, keep going, keep going. You are actually bypassing the inferior ulnar nerve even if it is in the center. First point. Buccally, anyways, if it is there, you are already bypassed it. Right? Even if it is in the center of the ridge also, you still bypassed it. Right? At the same time, you are actually below the mylohyoid muscle. You are actually avoiding all your lingual artery and everything there. Even the lingual nerve also, everything. You have bypassed all these vital structures.
5 to 10 degrees.
Only 5 to 10 degrees. If you do more, 25, 15, 25 like this, what will happen? You will actually come more superior, If I am doing like this, I will come more superior, But if I just do only 5 to 10 degree twist, straight below. You will get exactly second dip where? Below the mylohyoid muscle. The lingual cortical plate is there, Let us say for example, this is the lingual cortical plate, right? So what I am telling you is, you just come out like this and you have to just take it out. That's it. You will just come out, that's it, like this, second dip. And just come down. That's it, over. No need to go keep beyond. Clear? Right? That is how you do a nerve bypass. Same case in mental nerve region. Right? Mental nerve क्या करता है? ये थोड़ा टेढ़ा है. Right? This fellow is little arrogant fellow. What he will do? Right? He will say, I will not follow the rules. He goes anteriorly, takes a U-turn and then comes out. No. Right or wrong? Right? So he has gone anterior. Takes a turn. Now imagine, okay, it is not actually going lingual. It is again lying on the buccal side only. Taking a turn, coming out on the labial aspect only. Mental nerve comes on the labial aspect only, Right? So it has to be either in the straight or onto the labial aspect. There also, if you just go slightly lingual, same 5 to 10 degree angulation, you are bypassing the mental also.
5 to 10 degree from
Buccal to lingual.
buccal to lingual.
Till mental region. From canine to canine region, from lingual to buccal or labial. Understand?
Okay.
Okay. Opposite हो गया. In the posterior region, from buccal to
Lingual.
lingual. In the anterior region, from lingual to labial.
Lingual to lingual.
Okay, that is where you get sound bone, IFR, interforamen region, this area. Right? Maximum you can put 23, 24, 21 implant also you can do. Same, again second dip. Everywhere the concept is the same. See, maximum is what will come out here, not onto the skin I am saying. Don't think that you will come out of the skin, no. Right? Just imagine that, I have cut open my mandible here. Just imagine that I have cut open the mandible here, now I am drilling it here. So exactly you will come out here. Remove the drill bit. That's it over. Patient also will not feel any implant here, don't worry. Is that clear? Mental nerve bypass or whatever it is. If you have a CBCT, well and good. Okay, if you have, but don't insist. My whole point is that, right? So based on that also you can actually, decide your direction, right? So this is how you do a nerve bypass basically. Forget about the last diagram, that is a BOA, I think, BOI. That is a different implant. Okay. The rest of the, basically you do a bypass like that. Clear? Alright? So next, so I told you all these already, points to master, tactile perception, remember? Our main instruments are these two fingers. Okay? So these two fingers are very, very important to us. Alright? So remember this. Right? So tactile perception, develop that. In the initial stages, it's very important for you to do that. Right? You have to feel it. Otherwise, it might go wrong. Okay? So next is what? How to know whether you are in the cortex or a soft tissue. I told you R1, D1, R2, D2. When you know this, you will come to know whether you are in the soft tissue or in a sound bone. Clear? Alright? So next, implant insertion. See, basically the hand driver will be like this. Right? Whether it is GS implants or any other system. Right? So basically you have a hand driver. Right? So you load the abutment actually in it's a single piece implant, right? So basically you hold the abutment into the, right, onto the driver. Basically the driver will be like this. Now let us say this is abutment. You load that into that, take it out, right? But always put your finger support to the implant. Initially because it might slip for you when you are actually inserting, right? Now, when you are inserting the implant, right? When you are actually inserting the implant, so this is the abutment region, sorry, okay, this is the abutment region, this is the shaft, this is the load bearing thread, basically screw, right? So when you insert, so first insert this part, right here, onto the gingiva first. First secure it. Again, two fingers, secure it, right? See, this is very important, insertion wise, you have actually two holes to engage. Not just the outer one. The second one is also there, no? D2, remember? That is also there, no? So what will happen? The direction of the drilling should match with the direction of insertion. Sometimes what will happen is, again here also the same R1, D1, R2, D2 will come. Same thing will come when you are inserting. See how it will come? See, when I am actually rotating the implant, first you will get resistance. Right? After your 5-6 turns, implant will just go like this. Freely. It will keep on going freely. Why? I am in the cancellous bone. This is where you should be little careful. Why? Because what will happen? Now when you are actually rotating, when it goes into the loose bone, it might change the direction. It might change the direction. So to avoid this, right? Simple. Right? When you are actually tightening the implant, lot of people have this habit of raising their elbow and doing it. Have you seen this? They tighten it like this. So when they are actually giving the movement from the elbow from till the wrist, what will happen? You are actually changing a lot of direction. Right? So if you do one thing, simple, use your wrist only, not the elbow, first thing, right? Whenever you are tightening, this hand driver is there, this part, right? This part actually should rest on your palm. like this. And only your fingers should be moving, rotating it. Right? This will give a push. The palm will give a push force, little bit push, and then you rotate it. Slightly push it, rotate it. Push it, rotate it. Push it, rotate it. You will never change any direction. Exactly, you will go and engage onto the second cortex. This is how the sequence again. Same will come. Resistance 1, dip 1, resistance 2, dip 2 will come. Dip 2 will not come basically here because you are engaging into the cortex. Okay? That is where you will get a very sound torque. Right? Same. Since the abutment is already there onto the gingiva, right? Always tap and see. With your instrument, you will get a very nice bone. Talk, 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 talk. That sound should come. It means what? You have got a very good sound bone. If you get a dull sound, tuk, 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 better change the direction. Okay? Right? Like this you can actually make it out. Okay? And if you are actually doing in a extraction sockets, basically, not the shaft. If it is a healed case, well and good, no problem. Right? But whenever it, make sure that the abutment minimum is 4 mm should be there for us to get a retention for the caps, for the crowns. Right? Minimum 4 mm should be there. That I will fill in the prosthetic trimming and all. Okay? Right? So this is about your implant insertion. Right? So this is how it looks once we finish the case. Right? So these two are pterygoids basically. Right? See the direction. So what I was telling, if the angulation is like this, don't worry. Because I am not going to put any teeth on that. Right? My teeth will stop here only. Somewhere here. Or maximum onto this. But it will just have a metal covering here like this. That's it, extension. Okay? Because those are only for the axial support. Okay? Now this is a posterior wall of the sinus I was telling. If not pterygoid, no. If I did not get any retention there, no, what I would have done? I would have just put implants, 2 implants here into this actually. Into the posterior wall of the sinus. See here also there is a posterior wall of the sinus here. But since we could achieve a very good torque in the pterygoid region, we put two implants there. Right? So remember, if this implant, if I am using an 18 mm, remember, okay? If this I am using an 18 mm implant, this I will be using 21 mm implant. Why? Because I am coming little more anterior, no? So the distance will increase. Now nobody asked me what is the inter-implant distance. 3 mm. Right? Here also same, 3 mm. Okay, so 3 mm at least you have to maintain. Okay? So what is welding? Basically, the scientific term is called as a sin crystallization, right? Or nothing but called as a welding. So what you do basically is binding two similar metals together, right? So you take 1 or 1.5 mm titanium wire, right? And then you weld all the abutments together with one single wire. So it means what? You are actually splinting all the abutments as one unit now. So what is the advantage of this? It will prevent all the micro movements that will happen. Right? It will prevent derotation. Let us say for example 8 implants are very good torque. Right? Now 2 other implants, let us say they have a dull torque, means dull tapping sound, little bit. But when you are actually welding all these implants together, even these 2 implants also will be stabilized because of the 8 people. It's like a teamwork now. Now all 10 people at one place, means 1 now. Okay? So that is a major advantage. Right? If you can weld it. I am not saying it's mandatory. See, let us say if you get all the 20 implants, very sound torque, no need of welding. No need of welding. Okay? Don't lose the case that you don't have a welder. I know welder is expensive. Right? See, think as an investment. Right? If you can buy a welder, it's well and good. If you can't buy it, it's okay. you can actually rent it from somebody else, right? So just if you don't have a welder, but if you get a good torque, well and good, no problem. Okay? So what does it basically do? So it protects the implants from any micro movements during the healing phase. It reduces any mechanical stress also basically, and safety for the patient also. Okay? There won't be any kind of loosening, nothing.
सर हमने 72 आवर्स में तो प्रोसेस दे ही देना है तो फिर भी ट्रेनिंग करनी पड़ेगी
नहीं, अब वही बोल रहा हूँ मैं, जरूरत नहीं है. That is what I am saying. Sometimes even your prosthesis will only itself act as a splint, no? But if it is an extraction case, you can't give permanent prosthesis. Another hardly 10 minutes job. खाली वायर को अडाप्ट करना है. एक बार वायर अडाप्ट हो गया, then welding is just hardly 1 minute job, no? Just hold with the prongs are there ready made, that welder का. Just tuck 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 tuck, just like spot welding.
तो सर जब प्रोसेसेस देंगे तो उस वायर को उतार देंगे
नहीं, that will be included in the processes, no? वो बाहर दिखेगा नहीं, वही वो आपको प्रोसेस में इंक्लूड होगा.
वो इंप्रेशन में आ जाएगा.
वो इंप्रेशन में आ जाएगा. That's what I'm saying. If you are doing, and that I'll tell in the processes, I'll tell in the prosthetic part, what impression material you have to use and all these things we'll discuss in the process. Okay. So anyways, yeah, वो impression में आएगा, and that वो भी process में include होगा. कुछ बल्कि नहीं होगा, कुछ भी नहीं होगा. ठीक है, right? So basically there are advantages of welding, but if you have a welder, it's well and good. If you don't have a welder, still okay. But make sure that you get a good torque. Welder नहीं है, अगर torque नहीं आया, implant को निकाल दो. Again, put it in a different direction. Get the good torque, bend it in the whatever direction you want, and then take an impression. Simple. ऐसे भी कर सकते हैं. ऐसे नहीं है कि welding करना ही है करके. नहीं. It's not mandatory. That's the whole point. Okay? So this is how it looks. Basically once you weld it. Right? Basically all the abutments are actually joined as one unit. So here the clinical photo like this. Okay? If you can, you know what? You can even weld the two-piece implants also. Yeah. Put the abutments, same, once abutment is put, they appear like single unit only, no? Anyways, right? So take a 1 mm titanium wire and you can actually weld like this only. It will give an extra stability. It's not only meant to do basal implants, welding. You can do it for any, that is also titanium only, no? Same material only, grade 5 titanium only. Either you take basal or anything. It's a grade 5 titanium.
सर उसमें तो हम पिकअप इंप्रेशन लेते हैं ना क्योंकि बट के साथ ही.
Abutment
अच्छा फिर वो साथ में चला जाएगा.
इधर abutment भी already है ना जी. It's already there, no abutment here. There is no need of any other abutment. Either what you will do, you will actually put a transfer coping. Right? Then you take an impression. Because they are narrow abutments, no? Or you can directly take. I'll explain you there how you do prosthetics and all. Okay? See, as you know, I don't practice actually prosthetics or all this stuff. General dentistry, to be frank. From past 13 years, I do only surgery part. My wife takes care of all prosthetic part, basically. So I don't do. Okay. So even in clinical practice also, I don't practice general dentistry. Zero. So if you ask me to use an aerotor, I don't know how to use now. I forgot. To be honest with you guys. Okay. I mean more into surgery. Okay. From beginning, rhinoplasty, hair transplant, all these things. Okay. So anyways, let's not go into that. So this is how it looks. Right? So now, next. What is the advantages of basal implants? Saves a lot of time, saves your expenses. Right? Because they are much cheaper. Right? Basal implants are not so expensive, right? When you compare with the two-piece implants. But the number of implants altogether, if you see, it will be the same only, the cost. Right? Because यहाँ पे 2 इम्प्लांट प्लेस करना है, so एक इम्प्लांट को कॉस्ट वहाँ पे 4 पैसा रहते हैं, यहाँ पे 2 इम्प्लांट्स का भी उतना ही कॉस्ट है. So don't lessen the cost to the patient. Just because you are getting for 2,000 or 2,500 an implant, please don't lessen the cost to the patient. Don't be in the mindset that मेरे को cost कम करना है. If you are charging per implant 25,000, here also charge the same thing. I don't know what are the charges here. I just told you an example. If you are charging 50,000 an implant, please charge it. Same thing.
We can charge premium because we are giving truth.
Exactly. You should charge premium prices only. In my clinic, full mouth I charge 4 lakhs with Basal. I give metal ceramic only, not even zirconia or anything. Right? We charge 4 lakhs. Right? For a full mouth case. Why? I am rehabilitating you, boss, within 1 week. Because I send all my prosthetic work to my wife, send it to dental care only, to Kerala. Right? So, 1 hafta to lagega. So, temporary I get it done in Hyderabad only, within 72 hours. Even if it is a healed case, I will give it temporary. Right? Cold cure. They will make it a cold cure or a heat cure one. Within just 24 hours, they will give it to you. Right? Wait for 1 week. That will come back. We will remove this and place the permanents. Right? No, actually, you should charge more, as Dr. Aman said, because you are actually giving the patient functionality back in very fast. No?
It's more convincing for the patient that I'm charging you more because I'm giving you it in 3 days.
Exactly. You will be able to eat whatever you want to in just 3 days' time. Right? Good. Right? So saves time. Obviously, right? Next, no problem of screw loosening, which is the most common in cases of two-piece. See, even I have faced so many, right? We talk about failure. I have recently done to my house owner actually. He got some DO implants somewhere, right? The implants broke. Can you believe this? I have taken an opinion and see the 2 implants what they have given a bridge, the implants, they were broken inside. Can't retrieve them because there is bone loss for me again. So what I did, I put Basal only. I took GS only. Right? I put 3 GS implants there. Instead of, I did not remove those 2. But instead, I taken the nasal teeth support also, put 3 implants, taken the nasal teeth support and then gave 5, 6, 7. Right? So like that, there won't be problem. He came with this problem only, screw loosening. Har ek bar aayega, I just tighten it. Right? He is not actually my case. Means somewhere else he got it done. So I did not even have the hex of that DO implants. I got it from somebody. And then I used to tighten it. Again after 1 month again he used to come back. Again tighten it. This time for 3rd time, it was not even going inside. It was just rotating there only. Then I took an OPG and saw there was a radial lucency actually in the implant. Then I opened the flap and saw, when I debrided that area, pieces of implant came out. So implant actually fractured. 2 implants, Bobby. 2-piece car.
I have 10 X-rays done by me that those are fractured.
Oh, hota hai. Right? So, see, if 2-piece fails, Basal is a solution. If Basal fails, Basal is only solution. Simple. Right? So, flapless again, very less penetration, diameter. Flapless, please practice flapless only. Right? Don't go for surgical stents and all this stuff. Your 2 fingers are more than enough for like a surgical stent. Okay? No need. Don't be too expensive. Okay? And obviously, ideal for beginners. Right? It's very much ideal for beginner. Okay? Right? So next. So complications. Basically, majorly I already discussed. Anesthesia, generally there won't be any complications, right? But the only issue is anaphylaxis, right? If the patient, better always test it, right? Just subdermally, just give 1 drop or 2 drops and then, wait for a couple of minutes and wait for any untoward reactions or whatever it is, right? General complications only you will get. Other than that, anesthesia, no more complications will come generally. right? Because the dosage whatever you give, they are not any toxic doses, right? So no problem actually in complications, right? If you follow the exact protocol, means again, the way I told you to give inferior lingual and blocks, no? If you give that way, no, you will not even that get complication of needle breakage also. Otherwise, that will come. Okay? Right? And same again in the maxilla, you can get only 2 complications. Whether you might get into the sinus, that's not a big deal. Right? If it is a sinus, nothing will happen. You will bleed for a couple of minutes, after that it will stop. Right? If you are actually into the 2 medial, I told you already, you will develop ecchymosis in the soft palate. If you are too lateral, you might damage, right, the terminal venous plexus, right. If that happens, again you have to put them on high dose of antibiotics, cold compressions, all these things. Regular things only will happen with implant, nothing will happen, okay. And mandible, very rarely you might get paresthesia or something like that. Okay? Paresthesia might happen if at all, if you damage any. See, paresthesia is what basically neuropraxic, right? It's not neurectomy. If you do a neurectomy, there will be anesthesia, there won't be any paresthesia. Right or wrong? If you cut a nerve, you will have only anesthesia, no? So it's always better to give anesthesia to the patient than paresthesia. Right? Paresthesia is an altered sensation, anesthesia is no sensation. Anyways, you are not having any problem with the functionality. The only advantage, if his wife slaps also, he will not feel any pain, no? Right or wrong? Right. So it's always better to give anesthesia to the patient rather than giving paresthesia. Let us say if the patient you develops any mental nerve paresthesia or something like that, right? Better thing is just open it, cauterize the mental nerve, means do a neurectomy, cauterize it totally and give anesthesia to the patient. Very rarely these things happen. But, yeah.
So repeat.
Which one?
If the patient
is having a long-standing mental nerve paresthesia and the patient is it's too bothersome, right? What you have to do, you can't just do a neurectomy, just cut it and just think that everything will be fine. No, neuromas develop. So what you have to do, the stump will be there, no? Inside the bone. That stump you have to cauterize it with a cautery. We have this cautery, no? उसे अच्छा cauterize करे तो क्या होता? Then the neuromas will not form. So patient will have total free of paresthesia. Only anesthesia will be there. No sensation. But that's fine, no? Because you are not doing anything with the motor nerve. It's a mental nerve, is a sensory. Right? That's okay. Better than paresthesia.
Yeah, like one
if
of
we
my
injuring the inferior aorta, then
Pardon?
if we injuring the
If you
inferior,
are injuring inferior aorta, generally paresthesia stays for 6 months to 1 year. That's it. Inferior aorta specifically.
one of my patient, she developed a mental nerve paresthesia. She was earlier she had total anesthesia, like she couldn't feel anything. Then after 4-5 months she started bothering me that doctor साहब यहाँ चीटियाँ काटती हैं, ये कुछ होता है. That like it was anesthesia was better than
No, no, seriously. No, that is actually, it is written somewhere in the textbooks also. I forgot the textbook name also, in surgical book only. It's always better to give anesthesia to the patient than paresthesia. Yes, it's scientifically written. I am not just saying as my statement. But how to do it, I just explained to you.
No, I'll call a neurosurgeon. Sir.
Yes, obviously.
so now we regenerate them.
That is why I said cauterize it. It will not regenerate. That is what I am saying. The whole point is telling that only. See, sometimes miracles happen. I will tell you why. One of my, my teacher was there. Okay. In my post-graduation. I will not take his name. Okay. We were doing a simple parasymphysis fracture. He was my teacher that time. I was a student. Okay. Final year. So, he was asking me to retract. I was retracting. He said, how retract karo? I still retracted. अरे क्या कर रहे हैं सुमंत और रिट्रैक्ट करो ना. मैं बोला खींचा mental nerve snap टका. Mental nerve bro means it's
Yes, sir.
cut. He immediately started panicking. Hey, get me 5-0 Prolin, get me A. And you know what? He sutured with the 5-0 Prolin. He did it, boss. And the patient did not have any anesthesia, any paresthesia. He was having normal sensation. Can you believe this? Miracles happen. Yeah, seriously. I have never seen anybody do, and it is not advisable and it's not scientifically proven also, that you actually do a nerve reunion with a 5-0 Prolin. You actually do with an 8-0 or a 9-0, that too under loops, with a 10x or something like that. With his bare eyes he did it. Simple, just like joining two tissues, he did not do any microneural surgery there. Huh? He just did it like this and patient actually, had a good thing. होता है कभी-कभी, right? Why it happened, even I don't know. Please don't ask me that. So these things happen. It's always better to give anesthesia. No. Sometimes in the healing phase, that what you said is right. People will feel like very dirty sensations. Something is biting there, something is crawling up there.
Yeah, now she's fine actually.
Now that will come down.
It's
It will
what,
take
2 years
six months to 1 year. Sometimes. It's all because of the pressure that's created on the nerve, basically. Okay. Sometimes you do impaction also, patient will develop, if it's deep seated. Surgical extraction if you do, wo bhi hoga. Alright? Right? So I think, so that is the end of the surgical aspects, basically. And now we will actually deal into the prosthetic aspects. We'll just take a 5-10 minutes break.
So we have lunch.
Yeah, lunch is there. Okay.
Yeah, the pizzas will get cold because weather is cold.
Yeah,
it's
cold.
like already half an hour the pizzas arrived.
Oh, okay, then we'll just finish it off fast, working lunch, and then this is just another half an hour to 1 hour's time, that's it, okay? Not much. Come and just play it, no?
Later. Oh yeah, sorry.
So welcome back, guys. So hope you're not sleepy, right? After delicious pizza.
Cold pizza.
Good that actually you got pizza. Otherwise, definitely even I would have felt sleepy actually. Anyways, now coming back. The morning was all the entire the surgical aspect, basically the anatomical aspect, how to drill, how to place an implant, all these things were there, right? Now moving on, we have the prosthetic aspects in the bicortical implantology. See, basically I don't see any not big difference actually between these two, other than you have to maintain a strict parallelism and all this stuff in cases of the conventional implants. But here near parallelism bhi chalega. It's not exactly parallelism because these are all isoelastic implants, right? They have this flexibility, slight flexibility. So in this, we'll just quickly have a revisit at all these things, whatever we are going to discuss, means in the prosthetic aspects. What we actually require in the means of designing a proper processes is, right, the fundamentals about the good occlusion, right, having a good mastication, right. These are the main things, that will actually, that decides the success rate of a processes, right. So keeping in this mind, right, so we'll be going through how to bend it, right, how to synchrotization again, trimming, impressions, cast, pouring, means how you should actually pour a cast. All these things will be covering, right, by articulation and all these things, right. So, see what I feel, it is not the surgery that is more important, actually it is the prosthetic that is more important, right? Means, final outcome is what we see or even the patient sees, right? So before even placing an implant, we should be actually able to visualize the final outcome. Right or wrong? Right. So you should actually plan your prosthesis beforehand. how you are actually going to design the processes, how you are actually going to, take the occlusion into, consideration, or his previous photographs or whatever it is, whether he was having a skeletal class 3 or, class 1 or class 2 occlusion, whatever it is, right? So it's not about the surgery that is more important, it is about the prosthetics actually that is more important. Right or wrong? Right? So always remember, so they should both go hand in hand actually. Means the surgical planning and even the prosthetic planning should actually go in tandem. Right? So you can't design it or you can't decide it separately. Right? पहले मैं implant place करूँगा, उसके बाद मैं prosthetic plan करूँगा, वो कभी success नहीं आएगा. Probably you'll end up making a lot of adjustments to that. Right or wrong? But instead, if you can actually go hand in hand with the surgery and the prosthetics, then definitely you'll get a very good success rate. Okay? So, as I said, the fundamental knowledge required to frame basically a good prosthesis, right, will require the knowledge of occlusion, basically the mastication, the loading forces, right, or the axial or the lateral or vertical forces, right, and then steps in fabrication of the prosthesis. Now, what are the principles of mastication? Very, very important point. Always remember that you should have a bilateral mastication. The one more reason for failure of bicortical implants is unilateral chewing habits. Right? Unilateral chewing habits. Right? So people have this habit, right? But you have to actually, train them to develop this new habit, right, of having a bilateral mastication, that too equal, right? So equal mastication should be our aim also, not just to the patient. Even our aim actually is to achieve a bilateral mastication, right? And now anterior contacts during lateral chewing movements are undesirable and risky, right? In cases of bicortical, or even in cases of even a full mouth rehabilitation, what we are talking about, right? So whenever we do a lateral excursion, right, lateral movements, right, basically anterior contact should not be there, right? So you understood that diagram, right? So MP is what? Mandibular plane, right? MMO is what? Maximum mouth opening, right? When I do a maximum mouth opening, right, the position of the mandibular plane means near the condyle process, right? So, and CO is a centric occlusion and CR is a centric relation. So centric occlusion is what? Basically maximum intercuspation, right? Right or wrong? Centric relation is what? Just when you open your mouth and then ask the patient to bite, so that all the cusps basically are in connection, right? When they have a tight contact, right? That is centric occlusion. Centric relation is what? When the condyle is actually in the superior or the posterior most position in the glenoid fossa. Right or wrong? Right? So that is the centric relation. So these both you have to record when you are actually taking the bite. To have a good, bilateral equal mastication if you need to have, right? These things are very important. Okay? So this diagram it shows, right? So I already explained this. What is centric occlusion and what is centric relation? Right? So centric occlusion is what? Maximum intercuspation. Now if you see the condyle, basically that is the reason whenever we do centric relation, we actually push back the mandible, right? Slightly. Right? So that your condyle is in the most superior posterior most position of the glenoid fossa and then you take the bite. That is the centric relation. Centric occlusion is what? Just open the mouth and ask him to clench the teeth. Is that clear? Alright? See, I am not going to definition and all. Okay? Do you want me to? Right? No, right? We are just thinking about only the practical point of view, right? So this is how it looks actually. Centric occlusal contacts, how it should be. Basically here if you see in the diagram, right? There should not be any kind of an anterior contact. Basically the proper origin should be maintained. Whenever the patient is bites, no? Right? There should not be any kind of anterior contact. Definitely that contact should not be there. from canine to canine, right? Posterior, yes, of course, it has to be there. It's just like a normal occlusion, means where your buccal cusp basically sits onto the buccal groove of the lower first molar. Same thing has to be maintained, right? If it is a skeletal class 3, right, where you cannot actually achieve class 1 or something, and edge to edge is also greater, right? So these are basically the centric occlusal contact points, right? If you see the diagram, you will understand, right? So basically the mesolingual cusp, right, mesopalatal cusp of the first molar sits into the central fossa of the mandibular first molar, right? So all these things is just a diagrammatic representation, nothing more than that, okay? Now what is an anterior guidance? Basically in harmony with the envelope of the function, right? So let us say for example, now when the patient moves his teeth anteriorly, right? Right or wrong? So when the patient is moving anteriorly or onto the lateral side, right? So basically whenever he is moving onto the, let us say he is moving onto the right side, right? The posterior teeth on the opposite side actually should disocclude. They should not stay in occlusion. Whenever I am giving a lateral movement, let us say for example, I bring it forward and do it onto the right side. And if you observe, the left side actually there won't be any occlusion. There will be disocclusion actually. So all these things, right, you should ensure that there are no interferences both in the anterior or in the posterior and the lateral movements. There should not be any kind of, contact. Specifically in the anterior region, there should not be any contact. Okay, right? So what are the requirements for an occlusal stability, right? Stable contacts of all teeth, right, of equal intensity in centric relation, right? So whenever I take the mandible to the superiormost posterior superior position, the glenoid fossa, right? So there should be a stable contact of all the molar teeth, including the premolars and all, right? Nice occlusion should come, right? That is our main aim. Second is what? Anterior guidance in harmony with the envelope of function. I told you, right? So basically, whenever I open the mouth or glide the mandible forwards or take it into the lateral movements, right? So this is what is going to happen. Disocclusion of all the posterior teeth during the mandibular protrusive movement. Now let us say I am not moving lateral. I am just bringing it forward, right? Now if you observe, there should be a disocclusion of all the posterior teeth on either side. This should happen. As a normal occlusion, whatever happens, it has to happen even in the processes in the basal implants process also, right? Same thing. Disocclusion of the posterior teeth on the non-working side, right? During the mandibular lateral movement. Now if I am moving on to the left side, right side, so all the left side is a non-working side, right? When I am chewing now, let us say for example onto the lateral excursion on the right side, the left side should disocclude. And vice versa. The same thing is vice versa again, the fifth point. Okay? So you have to make sure all these things are recorded. So evaluate. So what are the points we should actually see? We should evaluate the existing occlusion before the treatment. Right? We should know. Right? That is what I said. If it is totally edentulous, then you have to take a proper history. If he has any clinical photographs, previous photographs or whatever it is. Even if you can actually see his chin position, if it is a skeletal class 3, generally there will be more chin projection will be there, generally. Right or wrong? Right? But if there is not much of a chin projection, but you still see a class 3 kind of a scenario, it means what? Probably because of the resorption pattern, right? So the mandible has actually more enlarged and maxilla is constricted. So do class 3 basically, right? So you have to evaluate, right? And then you should frame an ideal treatment plan. What I am exactly, planning to give to this guy or to her or him or whatever it is, right? And then no premature contact. This is very important. Same thing, whenever we do a single unit also, let us see if I am replacing 1/6. If I am just done a root canal treatment, I have just given a crown also. We will make sure that there are no premature contacts, right? Otherwise, if there is a premature contact, what will happen? This side is not occlude, no? Right or wrong? So you have to actually, take away all those premature contacts, make sure that there is no premature contacts, right? And there is a stable contacts on the either side. Okay? Of course, shallow, and there should not be any non-axial loading. Right? Means too much of lateral forces should not be there. Right? You cannot place it too buccally or you cannot place it too palatally also. Right? You have to maintain that neutrality. That is what the whole point is, because even the surrounding soft tissue is there, no? Just like what we do for a complete denture, what we do? Same thing. You cannot place it too buccally or too palatally, right? You have to go in a neutral position, right? So and then cuspal angles, basically, you know what? Minimal posterior cuspal angle means what? Generally should not use a very high angle or sharp cusp, teeth in cases of implants. The more they shallow, the more successful it is. Cuspal angles should always be shallower. No need to, just like natural teeth, कैसे रहता वैसे रखने की जरूरत नहीं है भी. Means, you understand, right? So it should be more shallower. Right? So these all things basically then increase the cerebrum. Cantilever should not be there. Maximum try to avoid cantilever in basal implants. Because you have an option of keeping a posterior implant right here. You can always place pterygoid implants, you can always put an implant into the, posterior wall of the sinus. Then why to give a cantilever? There should be a posterior support. Try to avoid cantilevers altogether. If you really want a high successful, processes. So avoid cantilevers, please. Okay? Narrow occlusal plane, of course, and ideal occlusal contact. So aim of designing the implant process should be maximize your occlusal function. Of course, minimize harm to the opposing and adjacent structures, right? And then minimize the risk of fracture of the implant or superstructure. Right? Means processes with this metal framework will be there. No, superstructure is that here basically, right? And of course, you should not actually, do, overzealous bending or something like that where you can actually fracture the abutment itself. Or you can weaken the joint actually between the abutment and the shaft. Right? So those things you have to just take care. Right? And then reduce the risk of fracture of the implant, that's over, right? And the connecting components and protect the implant host interface. Okay? So, all these things basically you should keep in mind before you even design a prosthesis. If you really want a successful prosthesis, then all these things have to be kept in mind. Okay? So now, basically occlusion scenarios, one maxillary natural tooth versus maxillary mandibular implant supporter prosthesis. See, in cases of these, anything you can do. That is what in the morning discussion also I said, right? A natural tooth versus an implant. Right? But occlusion should be the same as you actually do. As you actually do in your own normal single tooth replacement, right? That same thing should be followed here. Now, if you see, the maxillary lingual cusp is a primary contacting cusp. Scenario is what? Maxillary natural tooth is there and mandibular implant supported prosthesis is there. Means lower is implant supported, upper is a natural tooth. So what is a contacting cusp? Is a mesolingual, mesopalatal cusp only, no? It will come and sit into the central fossa of the mandibular molar, lower mandibular molar. The same thing should happen. The central fossa of the implant crown broadened by 2 to 3 mm. Right? So basically, you should not maintain a deeper fossa basically. You should actually, have a broader surface, means increase the surface area, right? So that it exactly sits into the center. If you shallow it, if you make it more shallow, what will happen? It will not exactly sit into the center and the forces distributed will not go along the long axis of the implant. Right? Rather, it might create more of a lateral forces basically. Right? So for that reason, you have to just broaden it by 2 to 3 mm to receive the primary cusp from the maxillary natural tooth. Okay? And the lingual cusp of the implant crown placed out of occlusal contact to eliminate offset loads. Right? So basically, simple thing was what? The lingual cusp, This is a parallel cusp. Actually, this one should sit here. Okay, means this is this side teeth actually, right? So this is sitting here, and what he is saying, this should not contact this one. The lingual cusp is there, no, for the mandibular molar. That should not come in contact with the palatal cusp of the maxillary, because it will not create any kind of axial forces. Understood now? Right? So scenario 2, maxillary implant supported processes versus mandibular natural teeth is a reverse scenario. Right? So obviously what will happen now, where it is actually going and hitting now? The central force of the implant corona, same, mandibular buccal cusp is the primary contacting cusp, right? Here the buccal cusp, because we are not having a scissor bite here. Otherwise what will happen, if you keep it outside, it will have a cross bite kind of a situation, like a scissor bite, right? So the mandibular buccal cusp is actually the primary contacting cusp. So obviously what will you have to do? Same thing what you did for the mandibular molar, you have to do for the maxillary molar now. You have to broaden it so that this contacting cusp actually sits in the central force of the maxillary molar. Clear? Right? Same thing. Again, these two should not contact. Right? Scenario is the same, but the structure what we are actually building will be just reverse whatever we discussed for the first case. Okay. So scenario 3, both are implant supported processes. If both are implant supported processes, what we should do, right? So mandibular buccal cusp of the implant crown maintains the primary occlusal contact, right? And then widen the central force of the maxillary implant crown to receive the primary occlusal contact, same thing, okay? And maxillary buccal cusp maintains the aesthetics where required and prevent the cheek bite, right? Basically is what it should be like overlapping. You cannot actually give a scissor bite kind of a thing. If you broaden it too much, what will happen? The cheek is pushed inside, right? If the cheek is pushed inside, what will happen? Obviously the cheek bite will start to happen. No. So to avoid this, basically you have to just broaden the surface area so that exact contact point will be in the central force. Simply. Okay? Right? Same thing, not much of a difference. Maxillary implant supported process versus mandibular natural tooth might require a cross-arch relationship of the teeth. Okay? Now, processes, right, in a completely edentulous condition. What kind of a processes you can actually give, right, depends upon the amount of space you have, right? What kind of a processes you want to give, it all depends upon the amount of vertical dimension you have. You all know how to take the vertical dimension, right? Two stable points you measure, right? Vertical dimension VO at rest and at vertical dimension at occlusion. So, if the difference between the VO and VR, vertical dimension at rest and vertical dimension at occlusion is more, it should be ideally is 2 mm approximately, right? Means at rest it will be more, at occlusion it will be less. So if the VR is, means if the difference is more, means if you have a more space, right? So you can always give a hybrid denture, right? If the VD is more, you can always give a hybrid denture, but if there is a very reduced VD, you cannot give a hybrid denture. You can only give a ceramic fixed processes, right? Because if there is a reduced space, what will happen if you give a hybrid denture? You have to form a metal framework, right? Then over that the teeth will come, no? So there is no space. So what will happen? Even if the patient is talking, there will be clinking sound, tuck, 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 tuck. Right or wrong? So in that cases, what you have to do? You have to give a ceramic fixed processes if the VD is less. If the VD is more, vertical dimension you have a very good space. Then either of it you can give, but hybrid dentures you can give aram se wahan pe. Right? Now when you can give a zirconia prosthesis, zirconia prosthesis preferably if you are not welding the implants, abutments. If you are not at all welding the abutments, means syncrystallization you are not doing, and you have a good, right, torque and everything, you can directly go for a zirconia prosthesis, right? But if you are doing welding, right, The only condition that you want to do zirconia is you have to actually make a framework. Basically, on that you can give a zirconia crown, but directly you can't give if you are actually welding it. You have to make a metal framework over which you actually give a teeth.
Palo malo kind of.
Same, exactly, right? Otherwise, directly you can't give. Okay, but if you are not welding it, definitely you can give zirconia crowns directly. Okay? Now, ideal requirements of process.
दोबारा बताना
हाँ जी.
जहाँ भी स्पेस ज्यादा होगी वहाँ पे तो हम हाइब्रिड करेंगे
हाँ, जहाँ पे स्पेस कम में हो वहाँ पे फुल सेरामिक करेंगे.
जी
Means full ceramic or metal ceramic, whatever it is, right? Zirconia is what? Zirconia you should give only when you don't weld. अगर वेल्डिंग नहीं कर रहे आप,
वेल्डिंग नहीं कर रहे हैं
वेल्डिंग
वहाँ
कुछ भी नहीं कर रहे, PFM भी कर सकते हैं, zirconia भी कर सकते हैं, आपका मर्जी है.
अगर वेल्डिंग कर दी है तो zirconia नहीं करेंगे
नहीं करेंगे. अगर करना है तो then you can first build a framework, then you have to do zirconia on that framework only. Directly you can't. Simple. ठीक है? So what are the ideal requirements of processes is it should have a proper function, it should have a longevity, basically means it should come for more number of years, right? Good aesthetics, comfort to the patient, biocompatibility, of course, and it should protect all the soft tissue structures also surrounding it. It should not damage anything, right? So prosthetic components, right? Simple prosthetic protocol which even a clinician can easily master is simple. See, this one is a transfer coping. See, once you take, before taking an impression, right? These all things you might be already doing it, right? Before taking an impression, because of the narrow diameter of the abutments, means in the single piece implant, you actually first put the transfer. Sorry, can we just go back one slide? I think इसमें reverse है क्या?
हाँ.
अच्छा ये वाला है. हाँ, okay, sorry. हाँ. You have to actually put the transfer coping, right, onto the abutment, right? Now what will happen? You take the impression along with that. Now that will come onto the right impression, on which you put the lab analog, right? You put the lab analog, right? Now that is again cast pouring will be done, right? Then what will happen? Now this part actually will come onto the cast, right? Then you have to put the burnout caps. Okay? Why? Burnout caps are basically for wax patterns, basically. Okay? For wax patterns, right? For that reason you use burnout caps. Other than that, there is no requirement for it.
Lab purpose.
That is all lab purpose actually. Our purpose is only till here, till lab analogs. Okay? Clear? Right?
So what if we cut the abutment?
Abutment means what you kind of
if we reduce the
height of the abutment.
height of the abutment or angle of trimming की है
Actually, you can take impression directly like that only, right? You can actually directly take the impression, right? And then
Acrylic cast pouring.
huh?
Acrylic cast pouring.
You can actually do a pattern resin cast pouring. Cast pouring you can do with a pattern resin also. Acrylic cast pouring, simple.
Up to the implant levels.
Up to the implant level. Means abutment level, not
Abutment level.
the implant level. If you trim it,
फिर एक्रिलिक से बोर करना पड़ेगा
एक्रिलिक से पोर कर सकते हैं. अगर आपके पास पैटर्न रेजिन नहीं है, एक्रिलिक नहीं है, I'll come in the cast pouring. Okay? Or simple what you can do, stapler pins रहते हैं ना, cheapest thing what you can do is
So use it Basal to
used बर, staple pin जो भी रहते हैं ना, impression लेने के बाद वहाँ पे hollow आ जाता है ना, right? First stone अच्छे से टैप करके fill कर देना है, बीच में just put the staple pin. Stapler pin रहता है ना, क्लिप मारने के बाद पिन बाहर निकलता है ना, वो पिन बीच में रखना है बस. Then you put the normal cast pouring and all. Then it will not break.
Yeah, but acrylic is better. Pattern is better.
Pattern is better actually.
Acrylic is best.
Acrylic is best. ना अगर वो नहीं है, that is what I said. अगर वो टाइप है, अगर हमको नहीं मिला, then this thing you can do. Simplest thing what you can do is this thing. Pattern is ultimate.
We do that even for the conventional.
That is what I am saying.
Abutment level impressions.
Why? Because that abutment anyways is a narrow one. If you just put direct cast pour, it will break anyway sometimes. Because every time we don't do, no. हमारा टेक्नीशियन करेगा, नहीं तो कोई और असिस्टेंट करेगा. They don't have that much of patience to slowly open it. They'll simply do it like this, it will break. Right? So, rather than all these things, you can actually do that. Now, this is most important. Now, abutment bending. So, forget about the theory and all these things. Okay, I'll just tell you the practical way. Now, first of all, what is the advantage of bending? Right? Whenever you bend an abutment, the chances of derotation are reduced, first of all. Why? Derotation generally happens on a plane, means on the long axis. Right? You are actually, what you are doing by bending? You are actually bending the long axis also. You are actually, preventing it from derotating. Derotation generally happens like this. It doesn't happen like this. You understand what I am saying? Right? So, whenever you are bending an implant, you are actually preventing to some extent the derotation of the implant also. Right? Now, how to bend it? Right? You can bend it either with the same implant driver with which you load the implant, right? With that you can bend, or with the ratchet also. You get a ratchet also in the kit. Right? With the ratchet also you can actually bend the implant. Right? Now, bending is a process. Whenever you are bending, now let us say this is an abutment. Okay? This is abutment which I want to bend. Right? Now I am going to put a driver. Right? But just don't do it like this or like this or like this or like this. Right? Hold it as close as possible. Right? And you put your support of the fingers like this here. Okay? And then always give the bend. Right? First in a mesial or a distal direction. Never give the first direction with the buccal or a parietal. This is the biggest mistake they do. Right? Now let us say this is like this, the implant is put in a palatal direction. Now I want it straight. Right? I want it straight. So what I do, I just keep it like this. Don't do it immediately like this. If you are doing immediately like this, you are actually causing a kind of a bodily movement of the implant. You understand? Right? So instead of that, what you do, you just go mesial or a distal direction, which are based on the position of the other implants, right? So you just go in a mesial direction, right? While going mesial only, then come parietal straight like this. Now you understood? समझ में आया? नहीं समझ में आया?
Medial किया या distal किया?
हाँ.
थोड़ा करते
करते अभी ये now let us say this is a mesial, this is distal direction. This is buccal, this is palatal. Now I have to go palatal. मैं सीधा ऐसे नहीं कर सकता. तो क्या करना है? You have to come mesial, slowly. ऐसे mesial आते, then you have to bend it palatal. Got the point now? What I did, I came mesial and then coming, I bend it palatal. Then what will happen? There won't be any kind of a bodily movement first of all. And you will get a proper bend. And bending maximum up to 45 degrees only you should do. Don't do more than that. उससे ज़्यादा करे तो then you are actually increasing the chances of fracture of the abutment. At where? At the shaft level. Okay? Where it actually joins the shaft of the neck. There it is a chances. Okay? So now you understood how you have to bend? Okay? So what are the advantages of bending? So basically, it will break here somewhere actually. If at all, if it has to break. But touch wood, we did not get any breakage till now. I think you got only once, I think.
Till now 3 implants.
3,
out of 15,000 implants.
Almost so many implants he has put.
Not in my hand, in 3 different people.
In 3 different people's hands. So almost only 3 implants broke till date for him, in his experience. For me, touch wood, no implants broke. Because if you follow the protocol, there won't be any breakage.
2 of them tested actually, whether it break or not.
That is testing, that is different story. Means at what level it will break. Right? So if you do an acute totally, obviously ho nahi hai. Right? So like that. So what is the avoid body bending? Obviously, you have to bend only here at this level. You are seeing there, no? You cannot bend along the shaft. Right? This should not move. So the more closer you hold it, your fingers, right? You are actually, avoiding all the body bending and all these things. Okay? Okay? So next, what are the advantages? Near parallelism can be achieved, obviously, right? And then derotation can be avoided, as I explained you. Derotation definitely can be avoided when you actually do, bending, right? And then due to the force distribution, there is a reduced lateral moment and proper transmission of forces. Why? Because you are actually making them into you are bringing them into the occlusal plane. Right? So proper distribution of forces is there, and lateral forces by the cheeks, by the buccinator muscle, all these things can be avoided. Okay. Next, the property is unique for cortical implants, obviously. Single piece implants is a unique feature, where you can actually bend according to your requirement or the patient requirements. Right? Because again, otherwise, in two piece you have to customize it. Maximum 15 to 25 degrees will be there, means angle abutments. 25 तक की रहेगा ना उसमें, right? Then otherwise you have to anyways customizable or otherwise like that, right? And then obviously will facilitate distant cortical bone engagement. Obviously means what? Why that last point? Facilitate the distant cortical bone engagement. Now let us say for example here there is concave bone. I told you, right? Say I am contacting from here to here, but still I can bend them. Because I have an advantage of bending, that is why I am putting from a far off place into the nasal spine. Right or wrong? Because I have that feature there. Otherwise I can't do it, right? Okay? So, this is important. Which implants you can bend, which implants you cannot bend. Right? So, bendable type are, if you come to smooth surface implants, starting from 2.7 diameter, 3.5 diameter, right? 4.5 diameter, you can bend. If it is a smooth surface implant. If it is a rough surface implant, only 3.2 and 3.7 maximum is the diameter that you can bend. Beyond that, you cannot bend a rough surface implant, and you shouldn't also. Right? So that is why it is written in the non-bendable type. In smooth surface implants, all the wide diameter, 5, 5.5, 6.5, 7.5, you cannot bend them. You cannot and you shouldn't also try to bend it. Okay? And rough surface again, more than 3.7, 4.2, 4.7, all these things you cannot bend.
This must be for the GS implants.
Yeah, in our system.
Yeah.
It's all about the diameter.
It's basically about any system, the diameter actually, if you cross that diameter, it's a
It
non-bendable.
will damage the implant position.
That's it. Okay, even if it is simpla or mono, whichever it is. Okay. And length. Any length above 12 mm, you can bend. Based on the length of the implant, if you see, length of the implant, if it is 12 mm and above, then it is bendable. If it is below that, non-bendable. Right? The diameter again, 4.10 mm, 4.1 mm, and below only you can bend. Otherwise, you cannot bend. All the wide diameter you cannot bend. Okay?
Short and wide diameter you can't bend.
You can't bend. So this we already discussed actually, so let's not discuss too much. Basically it's done in intraoral only. See, the welder looks like that. If you don't know how the welding machine looks, it's exactly the same one. This is what we use. Okay? So these two actually hold the abutment and the implant together, and then it's like a spot welding. Tuck. You have to just spray water on it because little spark will come inside the mouth. No? So even to minimize that risk also, you can just spray water. It's a totally insulated one. Okay? So this we already, we have already discussed so many things about this. So microscopically it will actually look like this after welding. This is the implant basically, this is the, you should have a uniform bonding. This is how it looks. Okay, see, I'm not going into too much of pre-gas welding, post-gas, because that doesn't matter actually in doing a practical thing basically, right? But remember, practical, I'll just tell you, once you have welded it, no? Now let us say for example, this is abutment, this is implant surface, right? Now with the two prongs, have welded it, tuck, right? Don't remove it immediately. Wait for 2 seconds. Then you will get a proper welding. Because that now oxygen will be there, no, that will go away. Otherwise, you will again, it will deoxydize and again, it will again, the chances again, it will come off. So once you weld it, no, you get that sound, tuck, again, wait for 2 seconds, then remove it. Then it will stay. Proper welding will happen. Okay? So advantages again, same, predictable fixation and immobility of implants in the early stages itself, right? You can prevent all the micro movements and all. Less time for repairing the provisional restorations, obviously, right? And then increase the predictability of success, obviously. See, if you actually get torque, still you have welded it, you can आराम से सो सकते हैं अरे success हो गया करके, because it will prevent lot of headache for you in the future if you can weld it. Okay, till you get a welder, it's okay, you can practice it without welding, right? Once a welder comes, then you better to weld it. It should take hardly 10 minutes procedure, that's it. Okay, additionally 10 minutes. So now trimming. See, as in the morning I told you, make sure at least 4 mm of abutment should be lying above the gingiva for you to actually give a crown. Don't trim it too much. Right? See, sometimes there is a chance you might trim too much because, now let us say, upper teeth is there. Sorry, upper you have to giving implants. Right? Lower natural teeth are there. 8 supra-erupted. But upper you have given pterygoid implant. You have actually put it in a normal, ideal position only. But while trimming, know how much you trim because of the supra-eruption of 8, the abutment you will go on trimming, finally it will become micro abutment. Right? So what you have to do, better to inform the patient and remove that 8. Right or wrong? Right? Remove that 8. And trimming, as long as possible, whenever you are trimming with a metal trimming burr, don't use normal diamond burrs and all. Use a carbide burr, metal trimmer, right? So it will cut like a cake nicely, right? And whenever you are trimming, do it in the direction of your rotation of your implant. In a clockwise direction. You are actually tightening in a clockwise direction, no? So your trimming also should be in a clockwise direction. Whether if you are doing like this, in a vertical manner, so your trimming also should do like this, you should do. Don't do it in a reverse direction. Because that small micro movement also sometimes can create derotation. In the same direction of your rotation of your implant for tightening. Okay? So like that you have to trim. And then same thing about trimming. Now what you should actually care, obviously eye protection, both you and yourself and to the patient also, because sometimes some small flakes of metal might chip off, and sometimes with that high speed, sometimes it might come and fall. And then sufficient, obviously cool, and then tungsten carbide burrs we generally use, right? High evacuation section, all these things. You all know this, okay? Care what you have to take. Now impressions. See, impressions, if you ask me, if you are actually, you are not doing any welding, right? If you don't do any welding, right? Then you can actually take impression either with, putty or with an alginate. Your wish. Okay? If you are doing welding, better take only alginate impression. Putty is not required also. Why? Because there will be an undercut below the wire when you are actually welding, so putty will not come out easily. But alginate, what will happen when you take an impression actually here with the wire, let us say, right? Now let us say this is wire, this is abutment. Now whenever I am taking actually impression, the alginate actually flows over it, right? Now when I am actually, now it is recorded, right, inside. Inside the impression it is actually recorded. Now when I remove it, this extra whatever is there, no, it will actually come out along with the impression. But your wire impression is actually concealed under that alginate, no? So in that impression you need to cut that extra part. When you cut that extra part, means remove that extra pieces of alginate, no, then you will see this impression of the wire total. It's very easy because that you have to replicate onto the cast. You understood or shall I explain once more?
Explain.
Right?
उसको एजिनेट से प्रेशर लिया.
नहीं सिंपल है. अभी देखिए ये यहाँ पे वायर है, राइट, ये अबटमेंट है, ये वायर है, राइट. नाउ मैंने क्या किया, जस्ट इमेजिन देयर इज अ वायर हियर, ओके. मैंने क्या किया, आई हैव टेकन, आई पुट द अल्टरनेट इंप्रेशन, राइट. अब ये वायर क्या होता, राइट, अंदर है ना, अभी इंप्रेशन हैज एक्चुअली फ्लोन ओवर दिस, नो, राइट. अभी इंप्रेशन कहाँ पे है, यहाँ पे है, वायर का अंदर है यहाँ पे. So when I am removing the impression, what will happen? The alginate also flows over it and come out, but the impression of the wire is actually concealed by the alginate, no? So what I am saying, chop off this extra alginate. Impression में, you chop off this extra alginate with the probe, you can do that, or a baby blade. Just chop it off. You know where the wire is. Just chop it off, no? You will see a nice U-shaped wire totally impressed onto the cast. Then pour the cast. Cast pouring, how you have to do? Either do with the pattern resin, with the resin, or with the staple pins you can do, with an old burr you can do, whatever you want to use you can do. Or if you have an analog, means a transfer coping and all, that also you can do. All these things you can do. ठीक है? Right? Same. It is recommended to split them with the light cure composite before the impression is taken to avoid the dislocation of the, if at all if you are using the transfer analogs. Okay, to stimulate this gingival, this thing will be there. No, what is it? GI. Gingival mask. So cast pouring, same thing. Here you actually use gingival mask actually, but generally technician's job basically, right? We generally don't do all this, right? So but in general, if you are doing in your own clinic, same thing what we again repeated. Cast pouring can be done with an acrylic, right? First only up to the implant level, right? Only the implant level impression you can actually do with the acrylic. Then remaining cast again you can pour with the stone by stone, right? So you will actually get a nice cast. So bite registration. Similarly, how you do, we generally do with normal modeling wax only. Right? So bite registration definitely you have to take. Even if it is a single unit also you have to take. Right? Because you will not have headaches later on. There won't be any kind of trimming and all this stuff. Right? But the thing is that here, definitely when you are taking, that centric relation that you have to, record it. You cannot just take only in CO, centric occlusion. Right? You have to actually practically hold the mandible backwards and then only ask him to bite. That bite you have to take. You cannot just take only a normal touch karke bite. No. Right? See how to do this, you all know. Right? So BD, first you have to determine the vertical dimension. Right? So vertical dimension at rest. So we all know how to take at rest. So basically M, right? 1, 2, 3, whatever you want to say, lips should be slightly apart actually. Right? Whenever you do this, lips should be slightly apart at rest. You record that. Then ask him to bite. Revoke. Then ask him to take it back. Then you draw the lines basically just like you do for a complete denture. Same thing what you have to do it here. Just you do, even in I think traditional implants also you do the same thing. Right? Once the bite is there, then you articulate it. Right? So the height of the bite is determined by the anatomic landmark which gives the vertical dimension. I told you, right? So based on the vertical dimension at rest and occlusion, you have to minus that basically, right? At least you should maintain that 2 mm, right? That vertical dimension at rest and occlusion. Otherwise, they will keep on touching while talking also, right? If the VD is more, you can do hybrid denture. If the VD is less, PFM directly. Clear, right? So establishing same thing again, vertical dimension at rest, vertical dimension, already I explained this to you. So freeway space is that only. So the difference between V1 and VR, basically at rest and occlusion, is the freeway space. So that minimum 2 mm you should maintain. Right? If you don't maintain that 2 mm, tuck, 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 clanking sound will come while talking also. Right? So same articulation, right? Once you have a bite, obviously, so now you have a bite, you have a vertical dimension is determined, everything is determined. The same thing you have to actually transfer onto the articulator. Right? So once you articulate it, then you open, same thing again. Okay? If the VD is if you want to do a hybrid denture, then prepare a metal framework and then on that you give the teeth, right? All these things. So again, wax pattern, basically when you do frameworks basically, you put the burnout caps. You remember what I told? In the lab they put a burnout caps first of all on the analogs and then those actually the caps are burnt and then the metal is poured. So basically the wax pattern is prepared basically there. Okay. So there you have to be enough retentions made in the burnout caps because there is no chemical connection between the burnout caps and the pattern resin. Okay. So the entire construction of the frame from pattern resin must be covered with a thin layer of wax. Basically you are preparing a wax pattern. Once the burnout caps is gone, so obviously you have a wax pattern only remaining there, no? On which there will be a metal framework. Because that wax pattern will go and then replaced by the metal. Okay? Now metal drying. See now once the metal framework is ready, right? See now this is a little tricky here, right? See sometimes what will happen, no? The metal framework will actually sit difficulty on the cast itself because it is a rigid one. But don't worry about it. When you are actually trying it on the patient's mouth, no, it will sit more comfortably. Why? Because the implants are all isoelastic. Slight flexibility will be there. But on the cast that flexibility is not available. But make sure that definitely you have to do a metal drying. Because once you do a metal drying, again you have to take a bite. So before metal drying you took a bite registration, you articulated and everything, right? And then when you do a metal drying also, right? Again you have to repeat the bite again. Because any minor adjustments are there, again you can make it that time. But don't forget to take bite that in that stage. Just because metal drying सब कुछ ठीक है करके, please take a bite. That will be the final bite. Registration, ठीक है? Same metal drying basically. It is very important that the frame must be passive on the analogs and implants when the bridge is down. Means basically you should not force it. What it means to say is you cannot force it and say ठीक हो गया. नहीं, it will actually rebound. Right? In the final it will not sit also. So it should basically sit passively. No active forces applied. ठीक है? Is that clear? Right?
इसको फिर मिल के बनाना पड़ेगा कि मेटल करके बनाएंगे?
क्या जी?
जो मेटल फ्रेमवर्क है ये, इसको फिर मिल करके बनवाना है?
हाँ बनाते ना, स्लैब में ही बनाते ना.
लैब में जैसे मेटल को एक
वैक्स पैटर्न
बाय कास्टिंग.
कास्टिंग से भी कर सकते हैं, मिलिंग भी कर सकते हैं.
मिलिंग भी कर सकते हैं. मिलिंग डिफिकल्ट.
मिलिंग डिफिकल्ट होगा इसके लिए.
हाई ऑर्डर कर सकते हैं पार्टनर.
But this is for hybrid.
Yeah,
this is for hybrid.
Hybrid.
This is for hybrid.
This is for hybrid only. Okay. So in case of biparticle implants, it is more difficult to see the framework on the cast. That's what I explained. On the cast than in the patient's mouth. Because in the patient's mouth, actually the implants are slightly flexible, right? You can actually, it will sit freely, rather than on the cast. It's always difficult. Okay. So bite again registration. Always a second bite is taken during the metal train. I told you, right? You have to take it. Otherwise, you'll be in soup sometimes. Okay. So this is very useful, especially in full mouth. Especially in full mouth, obviously we generally take it in a full mouth. You can't take any chances. We cannot compromise here, right? So the metal frames have to be placed in the mouth during the bite taking. Same again, the midline, the horizontal plane, right, and the smile line have to be checked as well. What we do again, I'm saying, what we do for a complete denture, the same thing has to be replicated. By bite registration, the smile line, canine to canine का ये सब register करना ही है, right? And phonetics also has to be checked. All these things have to be repeated. Okay. And again, obviously, if in doubt, then again take a new VD also, right? Take a new vertical dimension now with the metal trial, right? And then check, maintain that freeway space, right? All these things. Now, after making the necessary adjustment, obviously, the final framework should be seated on the patient. Again, it should be a passive fit. Again, I told you the phonetics, aesthetic and occlusion has to be checked again. So all these things have to be checked in the metal drying stage. Once you are satisfied, even if the patient is satisfied, everything is okay, then only you proceed with the final processes. Okay? So, basically processes are different conditions, single tooth, segment, multiple segments, right? In the morning we discussed actually, right? If you do a single tooth replacement, how you have to maintain it, right? The winged clasp we have to give, single tooth. The Maryland bridge kind of, kind of a thing.
Maryland, sir, वो तो interior में है ना, posterior में नहीं ना possible.
Posterior में possible नहीं होगा, नहीं कर सकते actually, but थोड़ा broad होगा. थोड़ा broad होगा वहाँ पे.
Up to premolar again.
अरे up to premolar you can do.
Up to
molar मुश्किल ही है.
ठीक है. अब अगर मोलर है तो हम
दो लेना बेहतर है या दो implants डालना बेहतर है.
दो implants.
दो implants. नहीं अपर का दो बस है.
Two implants.
Two implants.
No need of flanges.
No need of any flanges. Only two implants more. Generally रहेगा. If at all if there is a migration of the tooth, if a long-standing edentalism है, the tooth is like this, migrated or the space is closed, then it will become difficult. Or what you can do is, you can actually, whenever you are placing two implants, always remember they should be, converging like this, apically diverging. Apically diverging, but crestally they are converging, right? Put two different length implants. हाँ, let us say for example यहाँ पे 15 का लगा है ना, तो इस तरफ जब जाते हैं ना 18 का लगाना है. Because why? Because if you put the same diameter, no, you can't actually tighten them properly. This will obstruct. The other one will obstruct, no, because you are placing them closely, not 3 mm apart. Right? When they should meet actually like this, right? So if I am putting an implant from here, if I am putting a 15 one only, what will happen? This will hamper, tightening process. So put an 18 one. So you have to trim means it will tighten, but you have to trim the abutment to this level. Simple. And then take an impression. And that too when you are actually putting them both in a diverging directions, and if you can weld, it's okay. If you don't weld also, it's okay. Because anyways you are giving a crown on these two, it will totally prevent the derotation. It will totally prevent the derotation.
Sir, if in any case 5, 6, 7 and 8 is missing.
6, 7 and 8.
8 is missing. So 3 implants are made.
Yes.
6 or 7.
6,
plus.
7.
3 implants.
3 implants. I told you, one implant
Extra
for the number of teeth you want to replace. Simple logic. Okay? Right? So, any processes is possible. Single tooth, segmental, multiple segments means right side either, left side either, कुछ भी कर सकते हैं processes. But make sure all these things, whatever we discuss, try-in, bite registration, all these things have to be followed, same as we follow for the regular stuff. Okay?
So इनका ब्रिज कन्वेंशनल इम्प्लांट से बन सकता है?
हाँ जी?
इनका ब्रिज कन्वेंशनल इम्प्लांट से
कर सकते हैं. I told you, beginning only I told, You can actually do multiple. Say for example, यहाँ पे मेरे को अच्छा bone है, right? I will put the conventional implants. यहाँ पे मेरे bone नहीं है, I will put basal implants. But still you can actually join these two. That is the advantage. That is the advantage. Okay.
कैसे कैलकुलेट होगा कितने इम्प्लांट डालेंगे?
No, that depends upon how many teeth you are actually replacing, no? Right or no? That all depends upon number of teeth you are replacing. If we know the clinical scenario, then we can decide how many teeth, how many implants we need to put. Like that.
ये कन्वेंशनल इम्प्लांट के साथ भी कंपैटिबल है और नेचुरल टूथ के साथ भी कंपैटिबल है.
Both. Okay? Now replacing a single tooth with a cortical implant, right? So this we already discussed. Wherever possible, place 2 implants of different lengths. I just now told you. Right? Because if you put an ideal length, you cannot tighten the other one. Because this will obstruct. And always make sure, if you can go parallel, it's okay, no problem. If you actually put them these two as a parallel implants also, there is no problem in putting it. There is no कोई दिक्कत ही नहीं है उसमें, right? But if you can diverge them and put like this, no, it is far more beneficial to you. Because even if you do like this, you can still bend them parallelly. अगर मैं ऐसे लगाया इम्प्लांट को, तो abutment को मैं क्या करता हूँ, ऐसे सीधा बेंड कर देता हूँ. If I am putting this implant, I will again bend this like this. So now externally they are like this. Parallel, but internally they are like this. Because by bending, what I am giving the advantage is, I am totally preventing the derotation. I am actually giving a higher success rate to my implant. Right? So that is how you generally, in all these areas, basically. So abutments again, they can be welded to prevent derotation if you have a welder. There is no point saying that, मैंने तो 2 ही implant डाला है, welding करना है क्या कर सकते, problem नहीं है. Right? You can always weld. There is no scenario saying that you cannot weld it. ठीक है? Done? Where a single implant is only possible, give crown with wings onto the adjacent tooth to prevent derotation. Flanges, basically, Maryland kind of thing. Okay? So, process is basically every effort to make a structure long last. It should be like a monument, right? So, if you actually take all the situations, means follow each step properly, right? For patient, actually, it should be like a मैंने किया है, आया मैं किया ऐसा नहीं, right? So for years together, he will just remember you, right? Next is what once it is done. So you need to actually maintenance of the the process is also, right? So this, see, when you are actually charging good amount, 3 lakh, 4 lakh, 5 lakhs, whatever it is, if you are charging for a full mouth, no, as a complimentary, Amazon में मिल जाएगा आपको. You can actually gift them. No, seriously. कितना है? It's only 2,000 rupees.
No, if you buy directly, it costs 1,500 rupees.
1,500, 1,500, right? So that we actually can actually gift it to the patient as a complimentary. They will remain all this only. They will forget about 4 lakh payment, but they will remember the doctor has given me a compliment of 1,500 rupees.
The MRP is 4,299. We have been gifting it to our patients.
Very good, excellent, right? So this always you can actually gift it to the patient. They'll feel so happy, right? So it's basically a water flosser kind of a thing, right? So any food lodgement, make sure that there is no food lodgement, nothing, right? So every 3-4 months, recall the patient. I mean, if they are from local, right? Every 4 months or 6 months or 8 months, always have a recall visit. Check if any problem is there, right? In an occlusion wise or implant wise or whatever it is, right? At least do a 1-year follow-up, right? So take 1-year follow-up pictures, maintain this data. It's very, very, very important for you, for future cases also, right? So you can always, well-maintained process performs better and longer, obviously, right? So prosthetic considerations for bicortical implants, non-parallelism of abutments, basically, I told you, right? Parallelism is not actually mandatory here. Near parallelism is more than enough. Exact parallel ऐसे रहना करके जरूरत नहीं है. just like in conventional implants, right? But here a non-parallelism is still allowed. Okay? So, bridges supported by natural teeth or two-piece implants, strict parallelism is mandatory. Right? Now if you see in the previous picture, are they parallel? Right? See the pterygoid how they are. Right? So what I was telling you, sir, now the teeth will come only till here. यहाँ पे दांत नहीं आएगा only, right? यहाँ पे खाली metal framework ऐसे इसको ऊपर आएगा, but cemented. See, all the crowns are cementable, only cemented only, right? So temporarily should be cemented with ZOE or IRM or whatever it is, so that you can remove them easily. Permanents better use GIC, right? Even if it's metal ceramic also you can use GIC. Right? Fix them, nothing will happen because उतना आसान से फेल होने वाला नहीं है, ठीक है? But in cases of natural teeth or two-piece abutments or implants, strict parallelism is mandatory. There is no second thought in this. Okay? So, strict parallelism is not mandatory in bicortical implants because bone is elastic. First thing, implants are isoelastic, as already mentioned now. Right? Concept of osteofixation is remote, in a remote cortical bone, means somewhere. Right? We are not actually towards the crest. We are actually far away from the loading forces. I told you, right? So, very often the distal most abutment is non-parallel to the anterior implant heads, obviously. The distal is always non-parallel. If you are giving a pterygoid implant, is it parallel? No way it is parallel. Right? It is at an angle of some 30 degrees or 25 degrees. Right? When you compare with the anterior implant. Not yet osseointegrated, right? Obviously. Osseointegration abhi nahi hoga. Because it is not osseointegrated, strict parallelism, there is still a micro movement. No, because of the elastic nature. So that will compensate for the non-parallelism. But if it is integrated, you can't do anything, right? That is the reason, in cases of that, you have to maintain a strict parallelism in the conventional implants. Here it is not mandatory. Okay? So obviously this bending is unique to bicortical implants only, and trimming of abutments also. Right? So prosthetic is same. Avoid unequal number of teeth bilaterally. Very important. Right? Always try to maintain the same number of teeth on either side. If you are giving 6 teeth here, give 6 teeth here only. Means up to first molar, if you are giving, give first molar, first molar, first molar. ऐसे नहीं है कि मैं यहाँ पे 7 लगा दिया, यहाँ पे 5 नहीं, ऐसे नहीं. So we told in the beginning itself, right? Bilaterally equal mastication. Right? The same thing has to be maintained. See, that is the wrong place. Means that into mark is there, no? You should not do like this. Right? मैं यहाँ पे अच्छा आया इसलिए मैंने see you understood the diagram, no? Right? We cannot wear unequal number of shoes, right? One tight, one loose, ऐसा नहीं पहन सकते ना. Similarly here also you have to maintain that synchrony. If you are giving till first molar, please give it till first molar. If you are giving till third molar, give third molar. Right? So like that you have to, because otherwise what will happen? Patient will develop unusual chewing patterns basically. Right? जिस तरफ ज़्यादा दांत है उस तरफ ही खाएगा ना उन्होंने. And unilateral chewing habit is not at all indicated in bicortical implants. Not just that. Even it affects the TMJ also, right? If you have a unilateral chewing habit, don't you think it will affect the temporomandibular joint? 100%. Right? So obviously don't do that, right? So this may lead to the bone loss, obviously. Disuse atrophy. Basically, the more you actually use them, actually ossification will happen. That's called disuse atrophy. You cannot just walk on one leg. Right? So never replace third molars. Actually not at all required, please don't do that. Okay? See this, do not set up the teeth in the second and the third molar regions, okay? Need not coincide with the position of the teeth, I told you, right? Pterygoids तो पीछे रहेगा, लेकिन दांत आगे रहेगा. Right? Because these are actually given for axial support. That does not matter that मैं वहाँ पे implant में वहीं पे दांत लगाऊंगा, नहीं. Conventional जैसे नहीं है. Right? थोड़ा हटके, you have to just Think like this. Okay? So balance, same again. See, balance your supporting polygon. I told you right in the morning. Occlusion always needs to be balanced anterior, posterior as well as bilaterally. So mandatory position of placing an implant is in the 3, 1, 3, 2, 3, 1, 7, 2, 7. Right? Means 7 basically. Canine and second molar region. कुछ भी करके वहां पे implants डालो. अगर 7 के region पे implants नहीं डाल सकते, then put a pterygoid or into the posterior wall of the sinus. But make sure you are giving an implant there. Otherwise, you will never get the supporting polygon finished. And अगर वो नहीं हुआ, prosthetic failure हो जाएगा. Clear? Right? So in conclusion, right? So if the basal implants are utilized, the burden of bone augmentation, waiting time, all these things are excluded from the dental implantology, right? And then in the concept of basal implantology, bi or multicortical anchorage is achieved, as we all discussed from the morning, right? Most importantly, the patient are able to return to normal masticatory function as soon as possible within 72 hours. And that is the reason, as Dr. Raman was saying, you can charge more, don't charge less. Right? So let us raise our standards. Let us not lower our standards. Right? So we'll raise our standards, charge more, give good service. Simple. Okay? And one of the biggest advantages of bicortical implants is that the number of failures is limited to the situations like overloading, unilateral chewing patterns. Failures are only due to this. Or even I said in the morning, improper placement of an implant. Placing an implant only till D1. You remember depression means dip 1. मेरे को dip 1 आया, बस I will not go beyond this. I will not drill. Right? And put an implant. Obviously you will get torque, but later on it will fail. So all these things you should remember. All the prosthetic considerations, whatever I discussed since morning, all these things again you have to keep in mind. Right? So finally, immediate loading is not an option for this concept, it is a pure necessity. I told you right in the morning also, it is mandatory. It is not an option or a choice that you make. It's just a mandatory thing, that's it. Clear? So always remember, you don't listen to the bone should listen to you. This is what my concept is always. Right? सुनना है तो मेरा बात सुनो, मैं तुम्हारा बात नहीं सुनूंगा. Simple. Where the bone is there, I am going to put an implant. Means, of course, intraocular. Clear? Right? So, with this, I conclude my prosthetic part also. Right? So, thank you very much for your patient listening. And I hope some concepts are clear. Right? So, any questions again? Please, you are open.
तो लाइगेचर वायर से उसको वेल्डिंग करते वैसे लाइगेचर वायर से बांध सकते हैं?
नहीं, उतना रिजिडिटी नहीं है.
और वो प्लेस किया डायरेक्टली इम्प्लांट तो डायरेक्ट इंप्रेशन ले सकते हैं?
हाँ.
मींस वो जो आपने प्रोस्थेसिस में इतना सब बताया ना,
नहीं डायरेक्ट ले सकते, वो लगाने की जरूरत नहीं है. आई अंडरस्टूड योर क्वेश्चन. यू नीड नॉट पुट ट्रांसफर एनालॉग, दैट्स व्हाट यू आर सेइंग ना. मैं ट्रांसफर एनालॉग लगा के ही इंप्रेशन लेना है क्या? नहीं, जरूरत नहीं है. यू कैन टेक एन इंप्रेशन डायरेक्टली विद एन alginate, राइट? देन कास्ट पोरिंग के टाइम पे, सिंस द अबटमेंट्स आर वेरी वी मींस नैरो डायमीटर, राइट, बेटर कास्ट पोरिंग पैटर्न रेजिन से कर लो, एटलीस्ट अप टू इम्प्लांट लेवल. बाकी का देन यू कैन पुट ऑन स्टोन. नहीं, अगर आपके पास रेजिन भी नहीं है वो टाइम पे, राइट? So what you can do, just pour cast means stone, then put a staple pin in the center of the abutments. Basically, howler रहेगा ना, ऐसा रहेगा ना abutment का impression. So put it in the center. The staple pins or or reamer, whatever you want to put. Cut the reamer or used burrs, whatever you want, you can actually put it like this, right? And then उसके ऊपर then post the cast stone, right? So you remove, it will not break.
अच्छा सर, आपने इसमें बोला ना इसमें माइक्रो मूवमेंट्स हैं.
रहेगा.
रहेगा। तो कन्वेंशनल में तो माइक्रो मूवमेंट्स नहीं रहने देते ना, उसमें तो नहीं होंगी। जब दोनों को बाइंड करेंगे तो मूवमेंट्स उधर भी जाएंगी कन्वेंशनल में।
समझा नहीं?
माइक्रो मूवमेंट्स हो जाएगा।
सर इसमें माइक्रो मूवमेंट्स रहेंगी ना, जो
उसको प्रिवेंट करने के लिए ही वेल्डिंग कर रहे हैं। अगर मीन्स if you get a high torque, there won't be any movement. The movement will happen only at the shaft level. Understand this, right? If at all, if there has to be a movement, now that implant body where it is now, actually it has three components, right? The threaded part, screw, the shaft and the abutment. Whatever the movement that has to happen, right? It happens at the shaft level, not at the base level, because it is already fixed into the bone. Why I am saying isoelastic, that minor जो movement होने के chances है isoelastic, because of the long shaft. Because of the long shaft, that will give a leeway for me, because of isoelasticity, to make a metal train sit properly. That will actually give me an access. But what you are saying, if you don't get a good torque, let us say for example, dull sound आया, not so great tuck sound आया when I am tapping on it, slight dull sound आया, then there is a chances of micro movement happening at the thread level, right? To prevent that, I am saying go a welding with the other implants which are actually seated properly.
सर दूसरा इम्प्लांट कन्वेंशनल इम्प्लांट है, उसमें तो माइक्रो मूवमेंट्स हम नहीं हो सकती ना।
नहीं हो सकता ना, उसको वेल्डिंग नहीं करेंगे ना।
अगर इसमें माइक्रो है और हम उसके साथ ब्रिज बनाए हैं तो उसको माइक्रो मूवमेंट जाएंगी ना।
किसको?
कन्वेंशनल।
And when you are, that is what I am saying. If the second implant, right? If you are using a mixture of an implant, right? This is, it is a conventional. This is a regular one. I mean, it's basal implant, right? What I am saying, if you are doing a combination of this, यहाँ पे इंटीग्रेट होगा तो माइक्रो मूवमेंट नहीं होगा. That is your point. यहाँ पे इंटीग्रेशन नहीं है, फिक्सेशन है, तो माइक्रो मूवमेंट के चांसेस है, right? What I am saying is, यहाँ पे भी इतने ही टॉर्क से आप लगाते हो. If the implant is put with the same torque and you get the same torque, then the micro movements will not be there. That is what my whole point is telling. And even this one also you can, the conventional implant also you can weld. Abutment. I told you in the morning only, right? Same 1 mm titanium wire, दोनों को weld कर दो.
So loading time तो different है ना.
इसलिए वो टाइमिंग भी डिफरेंट है ना आपका प्लेसमेंट का भी. पहले वो प्लेस करना है, उसके बाद 6 हफ्ते के बाद ये प्लेस करके इमीडिएटली लोड करना है. सिंपल है. तो लेट ही होगा ना. अगर पेशेंट ऑलरेडी इम्प्लांट से आया है आपके पास, लॉट ऑफ टाइम्स इट विल हैपन लाइक दिस ओनली. If it is a fresh case, we don't do it anyways.
Out of 4 implants, if 2 implants are failed one side, if the patient willing for the cortical now, then
like that,
we can mix the previous implants.
नहीं वेट करता हूँ उसके बाद 6 months फिर दोबारा.
No, that is what I am saying. If the patient has already walked up from other clinic, उनका abutments only lose हो रहा है, implant तो ठीक है अंदर, right? Only abutment is that screw tightening की वजह से उसको ही बार टाइट करना पड़ रहा है. So what we can suggest, we can actually give this one and that one only, right? We'll again put a new abutment, but now this time we'll weld both of them together. They're already integrated, no? Right or wrong? They're already integrated. यहाँ पे तो fixation immediate है. So directly wire से ये कर दो, करके immediate impression लेके immediate loading कर देना है. Simple.
Sir, your take on the fact that we don't connect tooth with an implant, conventional implant, क्योंकि वो tooth में we have PDL and micro movement. Here this is a rigid structure, ankylosed structure. तो यहाँ भी तो वो है ही है. Tooth will ultimately will lose the tooth.
PDL नहीं है ना, यहाँ पे तो fix हो गया ना.
But they will ultimately lose the tooth.
With fibers. Basically, tooth is actually suspended with the periodontal fibers in the bone. It is not attached, it is not ankylosed. Same thing, right? But here what is happening, here actually there is no integration, but that doesn't mean that the implant can actually swing upside and down. See, if you see microscopically, if you press on the tooth, right, the tooth is actually depressed into the socket little bit. Right or wrong? But in cases of basal implant, they are fixed. There is no kind of a depressibility. See, simple thing, whenever you are putting an implant, means a basal implant, make sure there is no grade 3 mobility of the implant. Grade 1 and grade 2 chalega. Means, bucco-palatal movement of the implant is allowed, still you can weld it to the adjacent teeth, adjacent implants. But depressibility should not be there. Just like grade 3 mobility. You got the point now, Dr. Raman, right?
Yeah.
Because वहाँ पे natural tooth पे at a microscopic level, if you, when you are eating also, there is a lot of movement, no? The teeth actually move when you eat. They are just, attached with the fibrous attachment. They are not ankylosed. That happens only in canines, means dogs basically. They don't have a PDL. Right? But in us, there is a movement. Here I am saying the movement is at the shaft level, not at the attachment level where it is threaded into the bone, fixed. The micro movement, that elasticity is in the shaft level, not at the threaded region. Right? So when placement itself, we have to be a little careful that there won't be any bodily movement. Depressibility should not be there. Simple, that's it. Got it? Clear?
The placement of pterygoid implant and posterior neuromethyl where can you please repeat that?
हाँ, your hands on अभी करेंगे ना? You tell it in the models. Directly show it on models.
होता है एक्स्ट्रा सीमेंट ऊपर से आ जाता है ताकि पेरिकोनाइटिस के चांसेस पेरिप्लाटाइटिस के चांसेस ना हो।
इसमें क्राउन के ऊपर
हाँ क्राउन के छोटे से छोटे
That is for actually tightening, no screw tightening के लिए ना। वो pre-implanted speaking of क्या मतलब है वहाँ पे? यहाँ पे तो कुछ ऐसे छोटे की जरूरत नहीं है।
जैसे हम नॉर्मल टूथ में
क्योंकि यहाँ पे टाइटनिंग ही नहीं होता ना बाद में, ये सिंगल पीस है ना।
सिंगल पीस ठीक
वहाँ पे the abutment is fixed to the shaft only, no? It's binded together, they are not separate.
So bending के time bone fracture के chances भी हैं?
Bone fracture हाँ हो सकता है, mostly in cases of maxilla. That is why I said always hold the maxilla with the 2 fingers when you are bending. ऐसे लगा के ऐसे नहीं करना है. कभी कभी क्या होता है, if there is a very high torque, right, and you want to, when you actually don't support it with the 2 fingers and you just bend it like this, what will happen? There might be a bodily movement happening and actually the implant can come out buccally or palatal if it is thin. Chances, but rare. If you actually hold it properly, no? ऐसे properly hold करके slow, don't give unnecessary force. Yes, slowly ऐसे नीचे लेके आके या distal लेके जाके ऐसे करना है बस, simple. Right? And actually bend it more than desired, because there is always a recoil, no? There is always a recoil. Right? So let us say, for example, you want to bend some 5 degree, so bend it 6 degree. Because finally it will come to 5 only. You will get the desired angle.
हाँ जी, good afternoon.
Like that.